Thursday, January 16th meeting of the Health Evidence Review Commission. I am Adrienne Irwin, and I will be chairing until Devin gets here, and I am calling this meeting to order. Daphne, did you want to conduct roll call?
Daphne is actually, she had to go home sick today, so I will be calling roll.
Oh, okay.
Just go through. Oh, I'm sorry, Jessica, go ahead. I had you do that. I'll do the public comment because that'll be great.
All right, we have Devin Kanzagora.
He is not, he'll be a few minutes late.
All right, Adrienne Irwin.
Here.
Mark Buckles.
Here.
Mike Collins.
I couldn't make it.
Stacy Geisler. Ben Huffman.
I'm here.
Max Kaiser.
Here.
Lisa Kouzes.
Here.
Linnea Lindsay. Lawrence Lyon.
I am here.
Chris Pinson.
Here.
Catherine Shable.
Here.
And Leslie.
Devin is here.
Oh, Devin is here.
Here.
And Leslie's here. Thank you.
Excellent.
What's that?
We keep going while you guys.
Sure.
I can actually go ahead with this staff report if you like.
Want to do the comment, please?
Oh, yes, the conflict of interest. So as we do it at the beginning of each meeting, does anyone have any conflict of interest to declare with respect to any items on today's agenda? Right. With that, I'll go into the rest of the staff report and then we'll go back to the minutes. So I think the biggest change is I attended a public meetings training and we were supposed to do a roll call for all votes. So Jessica will be doing our roll call today. And Jessica, when you do that, if you could make sure to make the chair last. The last name on the list, that would be great.
All right.
Daphne had to leave early today, so Jessica will be doing that, and I will be managing the public comment. The legislature is also coming to session soon. Some bills have dropped, one related to the benefit update project. We expect there to be more, but I don't have a lot more to report about that right now. We also have a new HERC work plan webpage. Liz, if you could bring that up. There's a lot of interest in our work with the benefit update project, and so we created a new webpage. It is searchable. It's right there on our homepage. You can see Liz bringing it up. And click it right there. And you can use the search bar, sort, you can filter, you can scroll through it. It's not all that long. But you can see it's got the specialty, it's organized by specialty area, and it has the key discussion items that we as staff expect to be the most controversial, and then the next meeting date and the next time we're publishing materials for each specialty group. So we'll keep updating that as the year goes along. But if you get questions about our work, that's a great resource to refer people to, or just to remind yourself where we're at with different things. As a part of that, you'll notice that some of the topics have dates on which you all don't meet, and that is because we'll assign some of those topics to our evidence-based guidelines subcommittee that normally does our coverage guidances. There's just enough work that we felt it important to bring that committee into that work. So we do have a coverage guidance coming to the February 6th meeting of EBGS, but then we'll spend the balance of that meeting working on the benefit update project, getting people oriented because it's a different kind of work, and then actually digging in as we are able. We are also still working to hire a medical director. Hopefully we'll have something to report well before your next meeting, but nothing official yet. And finally, we've been talking about the Disabilities Health Advisory Panel for several meetings now. That is still on hold. I've been talking to the advocates. We're having some good discussions. Still not sure where that's going to land. But stay tuned and feel free to reach out individually if you have questions about that. As you may recall, we had a listening session and a lot of the concerns people raised were about important issues that we couldn't really address at first. I make good use of everybody's time at the CNRG. I think that is all the issues on the staff report. Any questions or comments about any of that? Great. Then let's go through our opening presentation, Liz, and then I'll turn it back over to Devin. Just the regular opening slide. I'm sorry? Yeah, good point. We do need to bring that. Thank you. And we will probably get some public comment on this a little bit later. So Ben was kind enough to forward me some new guidance from the American Academy of Pediatrics regarding guidance they released in preprint about pandas and pans. And as you may recall, Kirk had a covered guidance and a guideline note on that topic, recommending some conservative therapies and then IVIG and plasmapheresis in select rare circumstances after certain specialist consultations. The AAP document raises some concerns about harms with those latter two treatments and recommends them only in rarer circumstances. Sort of a similar pathway, I would say, to what they're recommended, but maybe a little more restrictive. We did not put that on the agenda today. We're not looking for a vote on that. We are looking for direction from you all as a commission about whether you'd like us to go dive into the research, consider bringing that back as a future topic. Our norm is when something is covered, that it is covered unless we have new evidence of ineffectiveness or harms. And, you know, this isn't evidence exactly, it's a statement from the AAP, but we wanted to make you all aware of that. The other factor in this is that there is a commercial insurance mandate for Oregon state regulated insurance that mimics the coverage guidance that you all approve, which is kind of a unique circumstance.
And just to let you all know, the current guideline doesn't contradict the AAP guideline, it just is a little bit less strict.
That law doesn't apply to us, right? It applies to
Correct.
commercial.
That's a commercial.
And sorry, you're asking for input?
Yes, do you have it, would you like us to bring that back?
Or
Questions?
Do you just want us to note it and move on?
Well, I mean, I think if we're gonna ask for input, we should,
Let's hear the-
we need to be specific about what the differences are. I mean, we talked about it on a recent call, and that, in my eye, the differences were, they're qualitatively similar guidelines, and the restrictiveness had to do with the level of specialty involvement required to qualify for IVIG first.
And AAP recommended that this be done inpatient or monitored infusion center. We don't have wording about that in the guideline.
But otherwise, it seems similar to me, but I think if we're gonna talk about it, we should probably compare them, so.
Yeah, and we're not really prepared to go into depth on that. We did have some people note that we emailed about it and would like to testify. But before we take time for that, I just want to hear what questions you all have. Are you curious about this? Is this something you'd like us to bring back in more depth? Or is it, I think the fundamental question is a society guideline like that, is that enough trigger to warrant going deeper, or would you prefer to just leave it as is?
I mean, curious what you all think.
I think I'd want a little bit deeper, because it was a especially this was one of those discussions that was not based on strong evidence, there was a lot of expert input. And I think if another large, especially a national group, has very specific guidance that's new and can change some parts of that conversation, I think that's worth revisiting, discussing.
Others?
Um,
Oh,
Ben has his hand up.
as a pediatrician, I do respect the AAP and their guidelines are well versed and very scientific. So I would prefer to have it brought back for reevaluation.
I see Ben and Lisa. Lisa, I think you were first and
I'll
then.
listen to Ben first. Sure.
All right, I'll apologize in advance. So I think I personally would have voted differently had this clinical report been in existence. And I do feel like there's there's a significant difference between administration of IVIG and performing plasmapheresis. So I would echo Mark and suggest that we pull this back and have a discussion.
Hey, Lisa?
Okay, I'll do mine. So I'm kind of hiding behind the camera here. So I looked at the guidelines, the coverage guidelines, and didn't find a significant difference. I believe that AAP has maybe more subspecialist referral, but I made my recommendations based on barriers to care. And then as far as the adverse events from IVIG, I found one line in the document and it had 3 references, and I looked at those references and they were not designed specifically to look at the adverse events from IVIG. They were 3 of them, and I've been trying to find my notes because I noted it, but I can come back to it. But they were more consensus documents and specialist documents about pandas and not about IVIG interventions. My feeling is, personally, is to let it be how it is.
Yeah, I mean, my personal read of it, I think it's challenging. It's not, as to whether or not a new guideline should change what we do. I think it kind of depends on the circumstance and whether or not it's based on new evidence or not. In this case, the differences really are in terms of how much specialty involvement is required. We have, our guidance stipulates that there needs to be subspecialist involvement, but we spent a long time listening to public testimony and kind of massaging that guideline to balance concerns about overuse and harms and the need for specialty guidance with the public's concerns about access to care. And so if we were to align our guidance more closely with AAP's guidance, it would add further restrictions to access. So and correct me if I'm wrong, I think when we looked at this, it was, we require, you have to be in contact with a subspecialist. We allow for telehealth. I think AAP requires 2.
You require a multidisciplinary team
Yeah.
rather than a PCP and one specialist.
Yeah, and so then it gets into, well, the specialists are they likely to be in centers that would qualify as multidisciplinary teams anyways, and then and anyway, I think that would be the major difference, right? Do we want to add further restrictions? Initially, when we discussed this, right, I think we had requirements that were more stringent where we had the need to consult with 2 specialty clinics. And after hearing a lot of public testimony, we reversed that and made it 1 plus the PCP. So anyways, I think that's practically what we would be discussing. So now whether or not we want to do that, given other business before her, I think
Yeah,
is
so
something that.
sounds like we've got some interest in reopening it, have some reservations from some members. We also have some people here to testify. And how much time would you like to allow for that, Devin?
For the testimony?
Yeah.
Yeah, I think 10 minutes, we have a lot of other stuff to get through, but I mean, before we kind of officially reopen it, I mean, I don't think it's a small thing. I mean, this is gonna be, we spent a long time doing this the first time. And it's because there is a lot of public testimony and a lot of, it's an emotionally wrought topic. So I personally wouldn't want to reopen this, given the emotional fraughtness of it, unless we really thought that we were likely to change things. Obviously, can't do that without discussion. My feeling is the absence of new evidence, we're still left with the values and preferences of the community we serve. We kind of spent a lot of time already hearing about that. So if we are going to reopen it, I want to kind of vote on it or something before we do that, because I think we'd be spending several meetings going through this. A couple of people online.
And we do have 3 people registered, so if they get their 3 minutes, that would be 9.
Okay, yeah. Chris and then Ben.
Hi, my vote is not to reopen it. I read the guidance and it does sound like there's not new evidence. I wonder where it came from and whether there's just a lot of like general practitioners that are starting to do this, and then maybe that's why they wanted to just really highlight that it should be with a specialist. But there's also, it's not first line at all. It's pretty rare to begin with, and it was a very, very small population the first time we looked at this. So I'm just curious where it came from.
And just to let you all know, we did a claims search, which we know is imperfect. We may not have had the right codes, et cetera, but I believe, Liz, were there 2 claims?
Yeah, if we correctly identified all the, we identified 2 people.
Yeah.
Individuals
I think
who
the
got 3
system's-
rounds.
So that was another discussion for the group on the last leadership call. We said, well, one way to think about this is, in practice, are we seeing a big demand, or a lot of people kind of getting this? And it sounds like you already looked into it, and a couple of folks. Ben, you may have some inside, knowledge of what the rationale here was.
Yeah, so I mean, the thing that I think is most striking in the clinical report is the call for better data, and the acknowledgement that there is a significant paucity of data. In the absence of high quality data, often the best we have is expert consensus. And the Academy had not previously had any policy or guidance regarding PANS or PANDAS. And so I think what is new here is a guidance from expert consensus, which is, as I said, in the absence of randomized controlled trials, et cetera, the best we have. So I feel like there is, that consensus has never existed before. And so I feel like this is new. The fact that there aren't a lot of people, there's not a massive patient population who's requiring that therapy is not surprising. But I do think we owe it to our constituency to acknowledge that this is guidance and recommendations based on the best available evidence and expert consensus that didn't exist before, and treated as such.
Okay, fair enough. I mean, I would say that I don't know that our guidance qualifies as expert consensus, but it does to a certain extent, because we did spend a lot of time conversing with experts, and And the other thing to keep in mind, in the absence of strong evidence on benefits and harms, the other, values and preferences do play a role. If you look at grade guidance around guidelines. So, okay, Leslie.
Yeah, thank you. I agree with Ben. I also think it's really important to remember that this is a situation where we're talking about children, and it's oftentimes going to have a lack of data because studying kids is difficult at times. But also, I think it's important to continue to think of this is something that there is some new information. We are talking about children who are having an incredibly huge impact here. And I think it's really important to continue to think about, it's not about how many kids this is, it's about the kids that need the help. And that's why we're here. And I think the evidence has changed to me, and I think it's worth having that discussion. I also think this is an emerging topic and something that we are hearing more about. And I think we need to hear from the public about this. And I think we also need to open it up to have a discussion again among this commission, because to me, it does seem different. And again, these are kids we're talking about. And in these situations, sometimes we don't have all the data we'd love. And that's why we talk about the values and preferences. And we owe it to this conversation to continue. So thank you.
Yeah, I mean, I agree. I think we all agree with all of that. I think the question is, what would be new if we reopened it? All of that was true before, and it's going to continue to be true. And again, if there was a change, the movement would be in terms of further restriction to access, not less. In terms of aligning the two, the difference really is in terms of how specific we are in terms of the specialty consult requirement. So if we were to change things to align with AAP, it would, from the point of view of those that previously testified, it would be viewed as a slight increase in the barriers to access. Again, I'm not saying what we should do, but we have to balance all of this with, if we spend 3 meetings doing this, we're not spending 3 meetings doing something else. And there's going to be a lot of public testimony. We just have to decide whether the juice is worth the squeeze. Again, knowing that the question before us would be whether or not to place additional restrictions on access.
This is Chris. Appreciating the scope of what we have to do in the next year, is there a place where we could put it on a schedule to come back and review that would be realistic? So where it's a compromise between both, and maybe at that point there'll be more information, more data, but it would be like after 2027 or what, or somewhere towards the end of the scope of what we're trying to do with the BUP.
Yeah, maybe when we get further along with the BUP and kind of come back.
Is releasing something later in the year.
Okay. So we can maybe have it coincide with after that comes out.
But is there something else coming from AAP? You know?
It's gonna be published or something else.
It's just a preprint at this
We have a
point.
preprint, it's just.
I don't know if there are any studies that are currently going. There will not be another policy statement from the AAP. This is the policy statement.
Okay.
What I've heard from, I actually had someone call me and advocate specifically, and I saw it again in the public comment, that their feeling was that the right experts weren't consulted. So the community, the PANS community, didn't feel like the right people were at the table.
Yeah, we heard some of that the first time around. There was a lot. Again, this was not this was a tough one. I don't remember who all was on the committee when we did this, but
There was a lot of public interest.
it was not an easy one. So
Yeah.
it took a long time to get to where we got. So again, I would not personally want to open up Pandora's box unless we really thought there was something substantially different here. We've heard so much public testimony. We're going to hear some more in a little bit. And all of the public testimony is in one direction. And I don't think that's likely to be different. So we just have to kind of think about if it's worth spending a lot of time having a pretty good sense of where the discussion would head.
With that, should we do the testimony?
Yeah, okay, so we can go to the testimony.
Okay, so the first person registered is Sarah Lemley. And pardon me, we are a little short-staffed. It'll take me a moment to bring you off mute, but Sarah, if you could raise your hand.
I found Sarah.
You found her, great.
Should be allowed to talk.
I will read the orientation statement and then you can begin your testimony. So this next topic, as you've already heard, pandas and PAN, may be a sensitive discussion for some people. Just as a reminder for everyone, HERC is a policy-making body, cannot make decisions about coverage of care for individuals. Any policy changes resulting from today's discussion, in this case, we will not be voting on a policy change, it's just whether to bring the topic back to this group. But even then, it would go into effect at a future date. I know this is an intensely personal discussion for some of the people involved. And in this forum, we also need to talk about subjects in terms that can seem clinical and sometimes impersonal. Not every person's experience will fit into the picture that the evidence shows. Please be aware that our commission's business is to make the best possible decisions for the general population using our methodology and process to determine the importance of services. So with that, Sarah, if you could give your testimony, there's a timer on the screen that will guide you about the 3-minute time.
Thank you, Jason. Can you guys hear me?
Yes.
Okay, wonderful. Good afternoon. My name is Sarah Lemley, and I'm the Executive Director of the Northwest Panda PANS Network. We are appreciative to this HERC body who already spent 14 months deliberating the evidence on IVIG for Panda PANS, hearing from subject experts from across the country, and listening to so many community members who heavily advocated for the inclusion of IVIG coverage for OHP members. Prior to approval of IVIG by the HERC, IVIG was only accessible to those with the financial means to pay privately, highlighting a significant health inequity. The HERC addressed this health disparity by approving coverage of IVIG for pandas and PANS, not plasma exchange, but only after implementing guardrails to ensure the appropriate use of the treatment. There really should not be a concern that HERC guidance differs from that of the AAP because they are closely aligned. HERC's existing guidelines establish rigorous safeguards to ensure IVIG is used appropriately and only in severe cases. As far as restricting use to severe cases that the AAP talks about, HERC guidelines require patients to undergo clinically appropriate trials of 2 or more less intensive treatments before considering IVIG. Specialist oversight. IVIG can only be prescribed after consultation with a subspecialist alongside the patient's treating provider. As far as ongoing monitoring, patients receiving IVIG are reevaluated at 3 months to determine whether continued therapy is necessary and are subject to measurement of their symptoms by a validated instrument. These HERC measures echo the AAP's emphasis on careful patient evaluation, specialist consultation, and the use of specialized settings. We would urge HERC to recognize that its current guidelines are already consistent with the latest AAP recommendations and already represent a robust, evidence-based approach to treating children with PANS and PANDAS. Restricting or removing treatment options based on guidelines established by trusted expert organizations that came before these AAP guidelines that include PANDAS Physician Network and the PANS Research Consortium that published guidelines in 2017 puts this vulnerable patient population at serious risk. Without proper treatment, children may experience worsening psychological distress, mental health decline, severe weight loss requiring feeding tubes or IV hydration, or the progression of the illness into a chronic condition. In extreme cases, children may suffer symptoms for most of their waking hours. Some families have tragically lost these children due to suicide. There's no reason for a child to endure such suffering when expert developed treatment options are available. We ask today that the HERC focus its resources elsewhere rather than revisiting guidelines that are already in strong alignment with expert standards. In closing, Dr. Daines, who's a pediatric immunologist who is on the HERC expert committee that approved IVIG in 2022, is in agreement with not revisiting this topic and that the guidelines HERC put in place are still appropriate today. Thank you.
Thank you, Sarah. And next we have Kim McCormick.
Right, Kim, you are off mute. You should be allowed to talk now.
I'm so sorry. I had emailed Daphne that I'm not testifying today.
Oh, my apologies.
No worries.
Daphne had to leave early today. We apologize.
All right, and what about Dr. Natalie Parravicini? Are you here, or would you like to testify?
You should be off mute now, Natalie.
Thank you, I'm here. Unfortunately, the doctor is sick.
Oh.
So we'll be submitting more testimony in writing. But I am a naturopathic doctor and I see a lot of PANS and PANDAS cases because unfortunately, those cases are not being recognized in conventional medicine. I also attend the Neuroimmune Foundation conference every year for the past year, which includes leading researchers from throughout the world on issues of neuroinflammatory disorders, neuropsychiatric disorders. And what struck me is one of the doctors recognized that naturopathic doctors are seeing a large proportion of these patients because in conventional medicine, very often these patients are not being recognized for what they have and are being referred to just psychiatry and medication for psychiatric conditions. So the point that I'm making is that the American Academy of Pediatrics has not yet, is just now recognizing that PANS and PANDAS is a problem. And this paper is actually a huge step forward in that direction. The AMP started studying PANS and PANDAS in 2019 after PANDAS had been initially identified way back in 1998. The current report only mentions that they're going to be studying, but they're not really rescinding or mentioning that the consensus position is unhealthy or not viable. So I would recommend to leave the current guidelines in place because they reflect the consensus positions not only of experts, but of quite a few clinics who specialize in the treatment of these children, including clinics at Stanford University and other highly regarded institutions. This is not just a consensus position from a few experts. This is actually what has been practiced in the field since the first guidelines came out in 2004, 20 years ago. The number of cases that we refer to IVIG is extremely small, because nobody wants their child to be tethered to an IV infusion for 2 days. It's extremely rare. And the current guidelines already provide enough sufficient recommendations to ensure that the guidelines are applied properly without being a barrier to care. When a child is being referred to IVIG, they have often failed 2 or 3 or 4 treatments with first-line therapies. And they have to see a specialist in neurology. We work with neurologists at OHSU in Providence who review the cases. So it is already, the guidelines in existence are very practical and do not constitute a barrier to care. I think the AMP is catching up to 20 years of research, and I think it's a great step forward that we should support. Thank you.
Thank you very much. We hope you feel better. Is there anybody else scheduled to testify?
There was a Kirk Lord registered. I don't see him online.
Okay, any questions or thoughts from the committee? Otherwise, I'm gonna try to move us ahead because we still have one more testimony on unrelated topic, and then the rest of our agenda. Again, maybe chair's prerogative, but I don't want to tell us what to do, but I do want to move us along. My sense is that I don't think we're hearing anything that suggests that we should reopen this. I mean, it's going to be a huge kind of emotional, public set of public meetings, which we've already done. I don't anticipate much new, unless people feel strongly. I would suggest we kind of let this lie and come back to it, if and when new evidence comes out. Does that sound okay to folks?
Yes.
Okay. All right, so let's move on. We have one other testifier, right?
Well, we had 2 people register, but I only see one of them. And let me just ask if the second person, we had a Kai Liang from Trillium. Is that person online?
Looking for them. I do not see them, Jason.
Okay, and then in that case, we also have Paul Terdahl here to testify.
All right, Paul, you are off mute, so you should be able to testify now.
Great, thank you. Can you hear me okay?
Yes.
Yes.
Very good. Okay, so thank you. I am following up on previous testimony. So as I have discussed, I'm a volunteer health consumer advocate for individuals with autism and other disabilities, and the father of 2 children on OHP. I don't have any conflicts of interest to disclose. I do volunteer work with a number of groups, including Do No Harm and the Insurance Commissioners Insurance Advisory Committee, neither of which are directing or supporting the testimony I'm giving you today. As we have discussed previously, I'm calling upon you to do a medical technology assessment of gender-affirming treatment and to develop an evidence-based guideline. I'm also asking you to withdraw the endorsement in Guideline Note 127 for the WPATH Standards of Care WPATH 8. Rather than reading my entire statement to you, I would encourage you to take a look at it. I want to just address a couple of key points. I strongly support the right of individuals with gender distress to access medically necessary evidence-based care. This is something I have been advocating for since the Obama administration's work on the Section 1557 rules and the Insurance Commissioner's Mental Health Parity Bulletin back in 2014. I'm seriously concerned, however, that in the political furor of the last few years, that a lot has been lost, and services on the one hand are being oversold to patients who are being told, and their parents are being told, that these services are solidly supported by evidence and are medically necessary, and patients in many cases are being rushed into some highly invasive services that may not be well supported by evidence. At the same time, there's, again, political furor. I expect more next week, when we have a change in presidential administrations. It would really be helpful to have solid, impartial, expert medical guidance on what is the true state of evidence behind this. And that is something that I think you are better suited probably than any other body in the United States to do. And I would encourage you to do that. I have drafted a bill that will be dropped by the legislature next week that would give a specific call to you and specific direction to you to do that. And I would be happy to work with you on any discussions regarding that bill and to make sure that it is a good one. But I also think you can do that without waiting for the legislature to act. The second, regarding the endorsement of WPATH in Guideline 127, by endorsing WPATH and putting it in there, you have given the impression to consumers and policymakers that you have reviewed it and blessed it. And from my understanding of your meeting materials, that was really a pretty quick review that I don't think you even read the table of contents before endorsing it. And I would really encourage you to pull that back until you got a chance to do a more thorough review. Thank you.
Thank you. Okay, sorry, go ahead.
So sorry to interrupt, but we have a Sarah Lemley here. She had trouble logging in previously to the Zoom link, and she had been signed up in advance for testimony.
She already testified.
Oh, she already testified. Never mind.
Okay, so we don't have gender affirming care on the agenda today, but before we move on, any thoughts or comments from the group? Yeah, Larry.
Yeah. I have a question, and that is, do we have an objective standard set of criteria to determine when, if, how topics shall be revisited, and what that revisitation should consist of?
We have norms. They are not rules, so they can be changed by the will of the group. Normally, to restrict or remove coverage, we need to have either evidence that a service is ineffective or that it's causing harms.
I'm just wondering if we had an objective set with certain standards and what that revisitation should consist of and what it's based on, including perhaps cost of a particular service and number of patients affected. Maybe that would be, I'm wondering if that would be helpful.
It might, this is a bigger topic, Larry, that we can come back to. I mean, it's something that we've talked about, including, we've talked to state folks about, doing more data analysis to identify, areas that require attention, using data to kind of monitor use of things we've covered before to see if we need to come back to them and things like that. So we just started those discussions, a few months ago, and maybe we'll do more of that, but I don't think we have time on the agenda right now to craft a set of standards.
No, I'm not. Yeah, I'm not suggesting that we attempt to craft that now, but I'm just wondering if we had that set, that and it were and being very transparent, that may be very helpful to address some of the questions that are coming up in the comments, and also to develop a priority list.
Yeah, fair enough. And there are standards that guideline groups use to think about that honestly are new. That this idea of living guidelines are something that some societies are starting to play with, including the American College of Physicians. And even there, it's still in the kind of developmental phase. But we could possibly borrow some of those standards, some of which would be, is there new substantial evidence that would change, strength of evidence around different things that might bring it back up. So, which I think has already informally been part of the process for HERC. Okay, so I think we're going to move on. And with regard to gender affirming care, as a reminder to everybody, the state legislature had taken this up. Coverage is already the law of the state. The feeling of HERC was that it's obviously a very politically and emotionally wrought a topic, and we don't have a role in providing a coverage guidance. And so, since what we do is normally coverage guidance, it did not seem like a good use of the committee's time to wade into territory where we don't have a practical policy impact. In any case, if there's something comes through the legislature that directs us to look at the evidence, we certainly can and will do that. And if there's any other comments, let's move on. BBBS report.
Actually, we still need to do our opening slides.
Oh, opening
and,
slides, wow, okay.
And our minutes.
All right, oh, we never did the minutes, okay.
So,
You want to do that real quick? Approval of minutes from before. Any? What's that?
I have a motion to approve the minutes.
Oh, great, all right.
Second.
All right. All in favor of approving the minutes?
Oh, Jason.
Oh, yeah, sorry.
Jessica's actually gonna do the roll call.
Oh, yeah.
I'll
We
report.
have to do it for this too, huh?
You can't even
Yeah.
do a. another vote?
Yes, we have to do it for every vote.
Yes, I'm sorry, everybody, but that is what we were instructed. So go ahead, Jessica.
All right. Adrian Irwin,
Approve.
Mark Buckles,
Approve.
Mike Collins. Oh, they are absent.
Absent.
Stacy Geisler also absent. Ben Hoffman,
Approve.
Max Kaiser,
Approved.
Lisa Kuzes,
Approve.
Linnea Lindsay is absent.
No, I'm here. I've
Oh,
been
you're
here.
here. You've been here. That's right. You arrived late.
Approve.
Thank you. And Larry Lyon.
I believe I was absent, so I'm going to abstain.
All right. And Chris Pinson.
Here, approve.
Catherine Shable.
Approve.
Leslie Sutton. Oh, they may have computer issues. They may not be voting at this time. Devin Kanzagara.
Approved.
Motion passes.
All right, intro slides.
All right, I'll go through these fairly quickly. We have a lot of ground to cover today, but welcome to Good Advance List. The reminder, OHA has a set goal to eliminate health inequities by 2030. It's now 2025, so we're well along in that timeline. Our purpose today is to make coverage decisions for the Oregon Health Plan that will affect over 1 million OHP members, plus their providers, families, caregivers, friends. There won't be any decisions, as I said earlier, about individual care. This is a policy body. In advance. Decisions will be about coverage of benefits and medical necessity for the Oregon Health Plan. We will be, as you have heard already, hearing public comment. Our decisions will not be final until they're implemented at later dates. And in today's decisions, some of them will be implemented as soon as October, and others will wait until January 1st, 2027, when our operating rules change due to federal changes. In general, the considerations include our best assessment of the balance of benefits and harms based on evidence, patient values and preferences, stewardship of public resources, and the nature of our healthcare delivery system. Members, as much as you can, please be on camera and attentive. If you need to turn your camera off, but you're still present, please let us know that in the chat. If you have to step away, please let us know that in the chat. And in lieu of, since Daphne's not here, please message Jessica or myself with any logistical issues. And we ask that you speak up or raise your hand rather than using chat. Sometimes it's hard to keep track of the chat. Sometimes it's even hard for us here in the room to see when you raise your hand. So if you're not getting attention, just interrupt and just say, hey, I have something to say, and that you'll be given a turn. Other participants, members of the public, we have some public comment still to hear on one of the topics, but other than those who registered, you can put logistical questions in question and answer, and if they can be easily answered, we'll do that during the meeting. Otherwise, we will follow up afterwards. You can also email us, address we'll provide. The chat and the Q&A are part of the public record, and the meeting will be recorded, is being recorded and will be posted online. And there's the email address if you have anything you want to communicate with us about. So with that, we can go ahead. I think, oh, we do have one other item of business. So Chris Pinzone's term on VBBS will be expiring before our next meeting. She has indicated she is interested in being reappointed, and wonder if you all might take care of that. She's also being considered for reappointment by the governor and legislature. That'll happen separately, but this would be for, regardless of that outcome there, to continue her service on VBBS.
So moved. Do we move, make motion?
Do we-
Yeah, move to reappoint Chris Pinzon to the VBBS.
All right, and then we do a roll?
Yes, we
Yes.
can roll
Okay.
again.
Do it.
Call the vote. All right, Adrian Irwin,
Aye.
Mark Buckles,
Approve.
Ben Hoffman,
Approve.
Max Kaiser,
Approve.
Lisa Kouzes,
Approve.
Linnea Lindsay,
Approve.
Larry Lyon.
I'm sorry, it's hard for me to hear because there's an echo in the conference room. We are voting on the standards that Jason just said? Is
No, we're voting to reappoint Chris Pinzon to VBBS.
If any of you in the room
yes.
have your microphone unmuted, if you could mute your microphone, that could be causing the issue.
Yep. Yes.
Okay, so you vote yes, Dr. Lyon. And then is Chris allowed to vote?
I can abstain. Thank you all for your support.
Then Catherine Shable,
Yes, approve.
Leslie Sutton. They must be offline. Okay. And then Devin Kanzagara.
Yes. All right, fast with flying colors. All right.
Great.
All right, now, thank you, Chris, for volunteering. All right, should we dig in? Looks like diaper rash is the first on the list here.
Samarata. These are allowed, they're just changes
Okay.
that we made based on previous intent, they're just for your information.
Okay.
Straightforward or? Yes, so we met this morning and we had a very full agenda and people powered through it. It was amazing how much they all got done. The usual consent table of code pairings that need to be updated, as well as multiple guideline note changes that were considered very straightforward, were all approved as were in our meeting materials with no modifications. Does anyone have anything in that consent agenda that you want to pull out to discuss further?
Was there anything that was a sticky wicket that you would like her?
No. Most of it is stuff that we were discovering through the benefit updates project that just is dumb and needs correction.
Great.
So that's probably not the most professional way to say it, but we then had some new discussion items, hyperkinetic biliary.
Do you have the page numbers? If not, I can try to get them.
Consent table, I have page 61 of packet.
Page 61 then.
And
I'll
now
get
we're
them.
on hyperkinetic biliary, or do we want to vote on consent? Probably. Yeah, so there's a couple guidelines that no longer actually are needed because the codes aren't actually, the codes have been either, the descriptions have changed or they're not actually on the line that they just weren't needed. There's a couple of CPT codes that were added to a guideline. The AAP came out with guidance about silver diamine fluoride application in the medical office. We have a dental guidelines, we're adding the medical codes so that it'll be available in the medical office. And preventive services guideline had a code added to clarify a question. And then we had discussed at this body in October that the coverage guidance for hypoglossal nerve stimulation had kind of reached an impasse, that the current evidence body was fatally flawed in terms of study design. And there was a signal from our evidence folks that there might be better studies on the horizon, so they tabled it. So the decision at this group was to maintain non-coverage until further information published studies, et cetera. We didn't actually put that into a guideline, so we're updating our data blast review and guideline for non-coverage. I believe that's all.
Okay. Does this require a vote?
We should probably do consent first, and then we can just kind of do them in.
It's gonna get more complicated, so.
I know.
I move
Yeah,
to
well, that's what
approve
I'm
the
saying.
consent agenda.
I second.
Great. All right, let's do the roll.
Hey, Adrian Irwin,
Approve.
Mark Buckles,
Approve.
Ben Hoffman,
Approved.
Max Kaiser,
Yes.
Lisa Kouzes,
Yes.
Lene Lindsay,
Approve.
Larry Lyon.
I'm sorry, I did not understand what we were voting on. I'm looking on page 61. I'm sorry, I'm not seeing it.
Oh,
You're welcome to abstain if you don't feel like you have enough information.
yeah, this is the consent agenda, Larry, so unless somebody brings something specifically up, it's usually passed by consent.
I'll abstain then.
Okay.
Right, Chris Pinzon.
Yes.
All right, Catherine Shable,
Yes.
Leslie Sutton. Oh, they may have stepped out to take a call. And then Devin Kansagra.
Approved.
Kansagra, sorry. Approved. Okay.
Sorry, yeah. All right.
I would suggest that we vote on the three new discussion items as a group unless there's,
Yeah.
a lot of controversy and need. The first one is hyperkinetic biliary dyskinesia. This is where the
Okay.
gallbladder is
Wait, let's get the page number.
70.
Page 70.
So this is a condition where the gallbladder is overactive and kind of squeezes too much and can cause pain, cramping, et cetera, without a gallstone. We currently have a coverage guideline that outlines, when gallstones and biliary pains covered, also hypokinetic gallbladders, so gallbladders that aren't working well enough. And so we looked at the evidence and amended the guideline to say that we will also cover for hyperkinetic, which is over 80% on a test called a HIDA test. And then we did some restructuring of the current guideline. It doesn't actually change what the guideline's trying to say. We just think it actually clarified the wording and what the intent was. So it's basically just some restructuring. And then we will add this hyperkinetic biliary dyskinesia with an ejection fraction greater than 80% if they meet other criteria.
So for reference, we're on page 70.
Anyone have any questions or concerns or want to discuss hyperkinetic biliary dyskinesia?
So was Larry talking? Are you trying to say something, Larry? I'm sorry, are you on mute?
Yes, I'm muted. Jason texted me if I'm hearing better. People are speaking softly. There's a little bit of an echo because of the room that you are in. Difficult to understand, and people are speaking quickly, and that makes it very difficult to understand.
I apologize. I will speak more slowly and louder.
Thank you.
Okay, so it doesn't sound like there's any questions about hyperkinetic biliary dyskinesia.
The next topic was acellular. So the next two topics came out of the breast review, the breast surgery review for the below the line of the benefit updates project. The first is acellular dermal matrix for breast
Page 74.
When a breast surgeon does a mastectomy usually for cancer, maybe for other reasons, the surgeon will frequently place what they call an acellular dermal matrix into the surgical site in order to hold the implant or whatever the reconstructive technique they're going to do is. There are multiple ways to reconstruct a breast after it's removed, but this is one of the common ways. We currently have the code for acellular dermal matrix on our excluded guideline 2, and that's because of evidence of harm when it's a human product. The FDA came out a couple of years ago and reiterated that there's quite a few safety concerns with human acellular dermal matrix. However, there's not those concerns with non-human or synthetic. And unfortunately, it turns out that after multiple discussions with the breast surgeons, that there's only a single code for all of those products. It's just, and there's no way to distinguish what they're using. And that using this, they can sometimes do a 1-stage reconstruction instead of a 2. It's kind of complicated. It was sort of like, we should be covering this. And the surgeon should choose the best and safest product in their opinion, or a health plan might restrict it. I asked the CCO medical directors if they wanted a guideline. They felt that they wouldn't be able to manage it at that granular level. And so the decision, which really had no discussion this morning, was yes, we should add coverage to the breast cancer line for this. And similarly, our breast MRI guideline, so typically for breast
Page
cancer.
85.
Typically for breast cancer screening, women will undergo mammography. There are cases where a woman might need an MRI, particularly if she's very high risk because of perhaps a known gene mutation. We have a whole guideline outlining when an MRI would be appropriate. It's out of date with the current NCCN criteria, and so we modified the guideline. We took out a piece of it that was going into a lot of detail and basically just referred to NCCN. We had kind of outlined various genetic things, and now, there's so many more. So we're just and unfortunately, we have to reference a specific document. We can't reference the most current guideline, so we will be referencing version 2.2025.
Or its successor? I mean.
No, you can't.
Yeah, I know,
Right.
that's too bad.
I tried the same thing.
Generally, the successors are more expansive, and CCOs can follow the successor guidances, but we have to have a specific one in rule.
And that's legal DOJ.
Okay.
It's not, it's
Fair enough.
far
You've
beyond
looked
the
it up.
level
That's a
of
tough one.
influence. We're also adding coverage for a couple of additional diagnoses that NCCN included in there.
Is there a way we keep up to date?
I
with
have a
all of
list
those?
of all of the things that have NCCN references, and that's a standing item for November.
Okay.
But I've actually been surprised. I've put it together for November, and by the November meeting, there's already a new one.
I'm just so wondering, if IT, I mean, there's different ways of automating that. I don't know.
We publish a list twice a year, and we can't change the reference once it's in there, and there are super limitations.
That's a tough one with this topic.
Isn't there a state law about breast MRI?
No.
So there's one about dense breast notifications.
And
Oh, so
we have to cover clinical breast exams, which are only being done anymore. Yes,
Yeah,
there's a
remember
law
to
about
speak
that.
Were people not covering them?
Apparently.
Oh, okay.
All right.
It might date back 20 years.
It's a long time ago.
Let's vote.
Yeah, so these are the 3 new topics. If anyone has anything they want to discuss about them, I'm happy to entertain discussion. Otherwise,
Any thoughts or concerns? Hyperkinetic biliary dyskinesia, the acellular matrix for breast implants and breast MRI. All right, hearing none. We can move on. Anybody want to move?
Do we need to adopt those 3?
Yeah.
Those 3,
I
yeah.
move to adopt those 3 as presented.
Second.
no, actually, the biliary dyskinesia is modified, the other 2 are as
As-
presented.
As presented and.
Or presented, I guess, here.
No, presented here.
Yeah.
Yeah,
Careful,
second.
okay.
Yes, you're right, we didn't modify them anymore, so yes,
As presented.
Katie is correct.
Okay, good. And she did a second.
All right, so Jessica, we're ready.
Right. Adrian Irwin,
Approve.
Mark Buckles,
Agree.
Mike Collins.
He's gone.
Oh yeah, that's right. He's gone. Okay. Ben Hoffman,
Approve.
Max Kaiser,
Yes.
Lisa Kouzes,
Approve.
Linnea Lindsay,
Approve.
Larry Lyon,
Approve.
Chris Pinzon,
Approve.
Catherine Shable,
Yes.
Leslie Sutton. Are you back? No. Okay. Devin Ken Sagara.
Consagra.
Consagra.
Sagara. Okay, I will
That's
get it right, I
fine.
promise.
That's all right. Yeah, approved. Some of
Sounds
my patients just call me Dr. Devon, so, you know. it's fine. Yeah.
Okay. So we are on to
Biennial, the 2026 biennial review. We have
page 93 in your materials.
We have a liver transplant line below the funding line. The diagnoses that are on this line are on covered medical lines. According to the transplant consultants, they don't do transplants for these conditions. And so the proposal is to strike the line for October 1st and delete it for January 1st, 2026. One less line to go through the benefit update project.
Like a good idea.
That one actually has to get voted on, sorry.
We have to vote on it? Okay.
It's allowed.
All right, so deleting things that they don't do liver transplant for. What do you want to do? To move.
I so move.
Okay.
Second.
Jessica, we're ready.
Here we go again. Adrian Irwin.
Approve.
Mark Buckles.
Approve.
Ben Hoffman.
Approve.
Max Kaiser.
Approve.
Lisa Kouzes.
Approve.
Linnea Lindsay.
Approve.
Larry Lyon.
Approve.
Chris Pinson.
Approve.
Catherine Shable.
Approve.
Leslie Sutton, are you here? All right, and then
I want to hear
and
it.
then
Let's
Ken
see.
Did I get it?
Yeah, well, that one's fine. Approved.
Excellent.
Consagra, it's much easier than it looks. All the vowels make everybody freak out, but it's Consagra. Okay.
Benefit updates project. This is the bulk of the work that we did this morning. Jason, are we gonna do the slide?
Yeah, I think we
it's
should.
technically
This group, yeah. So this is page 95, but we're gonna have some slides before we.
Vote these individually? Or
No,
is it going to
we
be a
are
group
going,
after we edit?
I believe we're gonna vote on them as a group. What we did this morning is most were approved with certain things kind of tabled, like a certain diagnosis or a certain part of it tabled for staff to bring back. There was one that the whole thing was tabled, and then there was one we never got to.
Okay.
And you all can table even more if you want.
Yes,
We'll
or ask
get into
more,
that.
or
So
And-
this is a little different, so pay attention here, because it's not business as usual.
All right, I'm gonna close my computer.
All right, let's go ahead. So first a review, we did this last meeting, but it's worth doing again. Medical necessity is a concept used in healthcare, health insurance in the United States. It is used in federal law, but it is not defined. The law says, the federal Medicaid law says Medicaid can only pay and states can only receive federal matching funds for medically necessary services. Each state has its own definition. So you have to cover the medically necessary services, but each state defines them on its own. Larry, I see your hand.
Are you showing slides? Because I can't see them.
Yes, they
It's
might
not
be
being
behind
shared?
something on your screen.
The new Zoom also has 2 tabs on top if you're using an updated version, and you might need to flip the tab if you're just seeing people's names.
Okay.
Nothing like progress.
Okay.
This was a learning curve for me about 2 weeks ago when I was running a meeting, that
I think
there's
it
now
happened.
multiple tabs potentially at the top of your
Wow.
screen.
I just see the speaker and the gallery, but there's no slides.
Is there like a view option?
Try the view. Is there a view option with a little book and it looks like
Seriously,
dots on the
I
right?
am definitely sharing.
No, I know you are.
Oh, wait. No, no. I'm not.
Okay, I'm gonna start over here.
She's gonna unshare and reshare. Maybe that'll make it pop up for you.
Okay. Okay. There we go. Very good.
Yeah,
All right.
so where it says Liz Walker's screen, that's how you
Thank
get
you.
back there. So again, defined in, or not defined in federal law, but reference. And for the Oregon Health Plan, Oregon's definition of medical necessity and medically appropriate, which amounts to, Oregon has bifurcated the definition, but in federal terms, they both can make up Oregon's definition of medical necessity. Those are defined in our administrative rule 410.120.0000. And our HERC developed, and this is 2027 language, but it's very similar to what we have today with the prioritized list. We develop our code pairings and criteria, and those will define what is medically necessary for the Oregon Health Plan. So basically, HERC will codify and interpret those principles in policy. In addition, there are some agency rules, as we sometimes reference, quantity limits, brands, how to use which code, those sorts of things, and that will not change.
Is it fair to say that this is kind of what we've been doing all along?
It is. The more things change, the more they stay.
Yes,
Okay.
it's a lot less, a lot of the machinery inside what we hope will be the black box for 99% of our recipients is the same. But we're here to talk about the other 1%, so I have to go through this all with you. So let's go ahead. So as defined in state law, medically necessary includes these concepts you see in the bullets there. They're all things that are familiar to you, and those are referenced both in the medically necessary definition and the medically appropriate definition. We're not going to get into the nuances. Max can do that when he has hearings. And again, these are all goals. They're very compatible with the principles you all use to make decisions. Okay. Services that are not medically necessary. And again, here are some reasons you all decide not to cover things. When we talked in VBBS, I want to drill in especially on the last two, cosmetic and solely for the preference or convenience of the member. These tend to be the squishiest. What is for appearance? What is so disfiguring that it's hard to walk around in the street without having people stare at you and be able to participate in normal life? That will be your call here. And the exception to that is gender affirming treatment, where we have a state law that says things will not be defined because they are denied because they are cosmetic.
Yeah.
However, it also says they can be denied if they're not in alignment with accepted standards of care. And that's all adjudicated elsewhere, so we can stay away from that. There's some similar judgment calls on all the other criteria, what's unproven, what's proven, but that tends to be the most difficult one. So that is where your judgment will be really important to think, is this significant enough impact on somebody's appearance, their ability to function, that we should say that treatment is medically necessary. I also thought when Marcus Bachhuber, he developed the slides, by the way, it was great to have somebody with a little distance or a process do that. He suggested some plain language interpretation of all this for health reasons. So are we doing the service for health reasons or some other reason? And it's sort of a shorthand that might be more understandable to a lot of people. But this breaks it down a little bit more analytically. Next slide. So as with other states, OHP does not cover all medically necessary services. We discussed fertility services, very important, very necessary for many people. Unfortunately, not part of our benefit package in Oregon. Some dental services for adults, the canals, the crowns. It would take an act of the legislature to make those covered. And so unfortunately, that is not this body's purview. Drugs for sexual dysfunction, we're prohibited from covering those by federal law. Hair growth treatments, that would be more of an agency decision or an executive branch decision. And the same with eyeglasses, very medically necessary. You can see I'm wearing them right now. However, not covered because they are not in the benefit package. Nice little diagram that Marcus made. You can see it's kind of a window diagram. So top access, is it medically necessary? No or yes. If no, it's not going to be covered, whether or not it's in the benefit package, the horizontal axis. But if it is medically necessary, you can see in the upper right, it's gonna be covered. But unless it's not in the benefit package, in which case it won't be covered. So it has to be both medically necessary and part of the benefit package to be covered.
I have a question that's probably very rudimentary, but I just should know. Who decides or what body decides if it's in the package or not?
The
If it's-
legislature.
It's a combination.
It's legislature.
It's
Some
a
of it's
funding
federal, some of it's
Some of it's
our
federal.
legislature, some of it's administrative rule, some of it's,
It's over our heads.
yeah.
Just to be clear, that when you say benefits package, you're talking the prior slides, 5 criteria for things that are in the,
That we pay
acute
for.
treatment, chronic treatment, et cetera, and then not in the benefits package, eyeglasses, hair growth treatment.
Correct,
that's
not
what
in
you
the
mean?
state plan.
Right,
That's-
that's what you mean by
That's
benefits
the,
package.
in the OHP benefit package.
Yeah.
Yep.
And you can think of it similar, a refrigerator is necessary to keep your food in your house, but
And your insulin cold, but we might not pay for it.
but OHP might not pay for it unless some CCOs are doing flex
Yeah,
services.
That's right. That was
But our job
Promise
here
of the
is
CCO
not those
model.
flex services, it is the benefit package to which people are entitled by federal law. And food, housing, those other air conditioners, those sorts of things, not in the benefit package, provided through other means.
Okay.
And outside of perks ability
And
to add
most
something to the
importantly,
benefit
yes,
package.
just not on the table for our discussions here.
So I have a question about this because there are SDOH factors which are not in and of themselves medically necessary, but they can help to promote some of the things that we consider medically necessary. And so it just and some of those things have been covered by flex funds through the CCOs. And I believe that there is, correct me if I'm wrong, some movement of OHP to pay for some of those things. Is that correct?
Yeah, and I don't know if you were unable to hear, Larry, that's what we were just talking about. Those are things that happen under the Oregon Health Plan. Those are done through federal waivers. Those are not our job. They're done through other means. They're not technically a part of the core benefit package, which is our work. So it doesn't mean they're not important. In fact, there are some things that are important that aren't included even there. But our job is the core medical benefit, and so that's what we're talking about in this diagram.
Okay. The other question I had has to do with what's medically necessary. And I'm not suggesting that we go back and look at the public comments from today to run them through this process. But it seems to me that in terms of what's medically necessary and what's not medically necessary, it may be helpful to take the things from the comments and kind of run them through that medically necessary, not medically necessary black box, because I think that's where we wind up having where there. I'm wondering if that may be helpful. That's all.
Yeah, we can do that. Anytime something's on the bubble and you want us to bring up one of those slides, we can do that.
I mean, another way to, again, that's why I said earlier, this is, in my view, this is essentially what we've been doing all along. Pretty much everything we do in this committee is that, right? Is this medically necessary or not? And we probably spend the most time wrestling with those gray areas where, is something just for convenience, or is it something that actually will help somebody with adherence, or is there some, when the evidence isn't clear, is it something that's going to help with their health? So in my view, we're already pretty familiar with this process. We just haven't put these words around it.
Correct. Yeah, I think more, the surface of the water is calm. Underneath down here where we're working, there's stuff going on.
Hydrothermal vents, maybe?
Right, well, yeah. Hopefully not any tsunamis.
All right, keep going.
All right, and so medical necessity, how does it relate to our current coverage? So it's operationalized mainly through today the prioritized list and its guideline notes, tomorrow in 2027 through our code pairing groups and the guideline notes. So again, slight change. Same result most of the time.
And right now in our lines, there's code pairing, And so it's essentially, we're changing the name line to code pairing group, but there's still, if a diagnosis does not pair with a procedure, that procedure is not medically necessary for that diagnosis. It might be for a whole bunch of other diagnoses though.
Right. So depression, psychotherapy, you're probably not gonna get psychotherapy for your sprained ankle, or your broken
Although-
leg. Although you might from the chronic pain results.
pain model.
Exactly. If you have an abscess, incision and drainage should pair with that. If you have a heart attack, probably that's not the right treatment, right? Claims without a covered code pairing will generally be denied by the automatic system. So your job is to make sure that the most important, most common things fly through and get paid. The things on the bubble, or that need individual review can have guideline notes. Most services will just be covered for a core set, which we'll get into on the next slide.
I have a quick question about this. And I foresee potentially a problem, and it may also wind up being in the lap of clinicians. Depression, psychotherapy. So patients who have COPD often are depressed. So how does that throw a monkey wrench into, for instance, that diagnosis procedure dyad?
No, because when you see that patient, you would code them as having depression. Not all patients with COPD have depression.
Right.
Many patients with COPD may have comorbid depression, but when you saw them, you would say, okay, they also have depression. And as long as you tick that box, they would then conceivably qualify for an approved procedure like psychotherapy.
And a clinician's chart notes might reference a half dozen or a dozen conditions for a particular patient during a single visit, but procedure generally is associated with one of those, and that's the one we're concerned about.
Okay, all right, thank you.
I think this is why people get trained on coding. I'm horrible about it because I work at the VA, so we don't have to worry about it quite as much as I probably should, but
If we had a single
I think
payer
this is
system, people
this is
would
why
be like, paid.
this is why it matters. Okay,
So again, we maintain those code pairings, and then where we want to have more detailed criteria than can be expressed by the code pairings, we have the guidelines. So go ahead, advance. So for all diagnoses, and this is a discussion we'll have in a little more detail in a moment, but so this is true currently, and it will continue to be true under OHP today. If you come in with a stubbed toe or a heart attack or a broken leg or a bump on your arm that you're not sure what is, you will get office visits, diagnostic testing if it's medically necessary and ordered by the doctor, medication if prescribed and medically necessary according to the pharmacy criteria. And even if it's an unfunded condition today, the medication will be provided if it's a low-cost generic that's not subject to prior authorization. So that's today. Upper respiratory infections like the common cold, technically that's in the unfunded region, but all those things I just talked about, office visit, checks, x-ray, decongestants, actually currently covered. Diaper rash cream is the same way. More you want to add about that, Sarah?
No, I mean, basically, unfunded or uncovered or below the line is a misnomer for a lot of things. The baseline is that everybody gets an office evaluation, they even get a specialist consult if the diagnosis is unclear.
Right.
Medications that are, safe and inexpensive and not PA'd.
Is the term unfunded going away, or is that?
Yes.
Okay.
Next slide.
This going away.
That's where we're going to the next slide. So in the future, what's going to change, in addition to those office visits, diagnostic tests, and medications, not meditations, durable medical equipment will be covered for any of those diagnoses. So currently, if your provider orders you a brace or a splint or a crutch for a condition that's in the unfunded region, that could be denied just because the diagnosis is in the unfunded region, that's gonna go away. Same is true for medications. So today, if you're prescribed a medication for constipation, that's an unfunded condition, that can be denied simply because of the prioritized list. Future, it can't be denied because of that, but there may be other medical necessity or step therapy criteria to go through. So those two tabs there that say newly covered DME or newly covered ancillary service, that's what's changing with respect to all the diagnoses.
And it's a pretty minor change. I mean, most DME people need for something that's covered. Ancillary would be things like anesthesia for a procedure.
Should be covered now.
Yeah, and there's a lot of, a surgery might be done as an exception that's technically not covered, and we obviously would then cover the anesthesia or whatever else would be needed to make that happen.
So does this mean you can get a walker with that?
You still would need to meet DME criteria of not being stable with a cane or
Right, but it doesn't have
whatever.
to be compared.
Yeah, so one of your jobs though, on the first agenda item, there's a whole laundry list of diagnoses. If there's some durable medical equipment that we need to write criteria for related to those conditions, that would be a great thing to point out. In most cases, those conditions will just get the standard set of services. And by, the default would be cover when medically necessary, based on the CCO's prior authorization criteria.
Okay.
Looks like Lisa's having a thought.
I am having a thought. So I have a lot of experience with utilization review and fraud investigation and all that kind of stuff. And do we have any way of monitoring?
Yes, there's a whole.
DME has been
There's a
way
whole
to-
fraud, waste and abuse group, and DME is probably their number one.
Yeah.
And it's not our job.
Fair enough, but we do have a way of monitoring that.
The agency does, not
Thank you.
Yeah, so
Agency, fair enough.
we'll get into that stuff
Okay.
occasionally, like we have a
Good.
guideline on continuous glucose monitors, those would be DME. If there's one where clinical criteria are needed, we can develop one, but mostly we stay out of that.
Particularly with your example, of continuous glucose monitors, like as prescriptions / DME, sometimes Kirk weighs in on when clinical coverage is needed, but typically the agency and other has like frequency limitations, replacement, hours,
Redundancies.
how to order, blah, blah,
Cost
that's
alternative.
fraud, waste and abuse, all of that's there.
All right, and then, oh, we lost the slide.
That's the last slide, I'm sorry.
So, okay, so now we get to.
Yeah, almost done. Some additional services will be added based on her discussion. So for these unfunded diagnoses, we'll be looking at procedures, largely procedures, surgeries, procedures that aren't being covered today, although in some cases they are under the comorbidity rule, which will no longer exist. That's an extra step to get things covered around the funding line. Or EPSDT, which is our program for children that enables medically necessary services in the unfunded region to be covered. And that's actually was expanded on January 1st to include youth with special healthcare needs, which are certain people up to age 26 instead of 21 like EPSDT. So again, some of those will become available to adults and some that are currently not covered for adults under any circumstance because they're below the funding line will become covered. And that's so I've been talking about all this other stuff that's mostly not changing. That's what is changing. So we're looking at this whole big universe and we need to find out what we actually need to cover that's not already being covered, that is safe, that is effective, that meets those medically necessary criteria.
This is really helpful. I mean, I think that there was so much discussion and confusion around the waiver going away and the way things Oregon has been doing for decades now has changed, but really it's not changing that much. So to recap, the line, the prioritized list and the ordering of things and there being a funding line, which was the thing that was unique about Oregon, is going away. So Oregon won't be as unique anymore, but we're still unique in the thoroughness in
We're
which we do
still-
things, I think.
So we're still gonna have code pairings that are in code groupings,
Right,
that's
but
actually
they-
more than a lot of states have. A lot of states will be like, we pay for cholecystectomy, because we just trust that you're doing it right.
Right, so we're more
still gonna
thorough
have,
and precise, but the ordering of things, which is kind of the thing that, when I talk about hurt to people, is the thing that gets the most attention, that's going away. And the stuff here, there's, kind of diagnoses that have been left behind because they've been under the line for all this time. And we're rescuing some of these and seeing which ones need to be kind of paired with things and determine whether or not they're medically necessary. So that sounds like that's going to be the bulk of our work, is looking at these things that were below the line and we just need to look at them anew.
Yeah, so the way I kind of framed it this morning, what's current state, although it's not obvious from our prioritized list, is that everything gets an office visit, evaluation, testing, and maybe medications if, they're not something of concern. That's the baseline, that's what we're continuing. So there'll be no diagnoses that are unfunded. So every diagnosis will be paid for to get an office visit, and that's actually happening now.
Right.
Fibromyalgia is below the funding line. You can go to your doctor once a month for your regular check-in, and your doctor's getting paid for those office visits. So we're just basically making current state more obvious. So what our job, everything is what we're calling evaluation and medical management only, that everything gets that. What we need to decide is, do things need a little bit more? Do they need acupuncture? Do they need chiropractic services? Do they need psychotherapy? Do they need surgery? We can put them in a bucket with a surgery. We can say there's a guideline because this surgery is only really useful in these cases. And my approach, I took all of the lines below the funding line and kind of dealt them out by specialties so that I could meet with specialists. So you'll see things, and there's a broad category, for example, general surgery. There's a bunch of kind of unrelated things in there, but they were all things that a general surgeon would know about. So you'll see stuff in there. And some require surgery and some just need an office evaluation. So we'll kind of pick that apart. Then there are things where there's a lot more sort of detail. And then there's things where I ended up drawing from covered lines for ophthalmology, which actually got tabled today, so we won't talk about it. But talking to the ophthalmologist, our current coverage makes no sense. Like, we should cover treatment of the cornea, the front of the eye, or treatment of the retina, the back of the eye. And we have some things here and some things there and some things, and so I'm pulling covered and uncovered lines together to make some sort of a more coherent, logical form. So you'll see that for a few. And then a lot of them you'll just kind of see we're changing the words, but the book is the same. We're changing the title, but the book is the same. So we're going to be going through, there's a lot of things. UUS was super this morning and I got through everything but ophthalmology. So we have a lot. The way I'm presenting materials looks different. The summary is different. There's things at the front that are kind of the questions or just kind of a thing saying there's really not much changing here. It's just all technical wording changes. What happened this morning was, for most topics, somebody raised a question. They might say, this diagnosis seems like it should need a treatment. We don't want to go into a deep discussion about that. I flagged it. It will be looked at by me and staff, and we will bring that back in the future. There was one, the back surgery line that there were quite a few questions about. So the whole topic is tabled and will come back. Some of them were just approved as written. Everybody liked them. I think there was only one or two. Most had some sort of a change. And so what your job is either to look at so I wrote most of these. Marcus Bachhuber, who works for the Center for Evidence-Based Policy and is an internal medicine specialist, he did the double check, or I met with specialists. And we went through all of their stuff, and I I took their input into account, and I did call out, I didn't agree with them in certain cases, and so I called that out of the materials. So at least 2 eyes have looked at all of this, but your eyes are more important, are hugely important, and your brains. So you can either look at what we're proposing and what BBBS kind of said and say, yeah, that makes sense, and approve it. You can say, this diagnosis needs a little bit more work. I'm a little concerned about where you think this procedure goes. Hey, this guideline, I have some questions. Can we look at this again? We're not going to go into detail. We're not going to go in, like, really talk about it. I will flag those. They will come back. If there's like I said, like the back surgery one, there was a lot of questions that, but we're not going to vote on that. Most of them got approved with just a few things pulled out. And I will let you know. And you have other things that you want to pull out, we will pull those additional things out, and then you'll see them at a future meeting. Some of them are just consent. I was just asked to look, hey, is there a more specific code for this, or what is this? I have a question. Those might come back as consent items, and you won't need to see them. Some might come back as a brief discussion. I was asked to look at harms for this procedure. This is the data I found on harms. Okay. If there's a really in-depth discussion, you might not see it soon because we are prioritizing getting a first discussion out for things before we really get into nitty-gritty detail. The timeline we're discussing today, EBGS has some things on their agenda in February. We have more on our agenda in March. EBGS will probably have some in April. And we want everything to have had sort of a first go through by our May meeting. Not that we have to make final decisions on it all, but we want to first go through so that the public can comment on it, the CCOs can look at it, you all can kind of have a sense of where we're going. I want everything 99% decided by the November meeting because we need to have a complete proposal to give to the actuaries for a year. I say 99.9% because we know that things will come up even after we've all looked at it that we may have to fiddle around with a little bit.
All right, thank you for that really good orientation.
So the first group is medical visit, or actually so you'll have to apologize. I have to apologize, and hopefully you'll give me grace. Things have evolved as we've been working through all these, so sometimes names have changed or other things have changed. So medical evaluation and medical management only is the baseline. Everything gets that. No diagnosis can be not covered. It has to be in this group, or if not, somewhere else. So there are 25 or 30 lines below the funding line that are really things that just need a medical visit. A cold, influenza, where you might need medication, etc. There's several guidelines where we've kind of called out, well, you've got influenza bad enough to be in the hospital, we're paying for it. That's going to go away because it will just be like in medical evaluation includes ER visits because people just don't know what they have. And then if you're sick enough to meet admission criteria, we will pay for your admission. So office visit only, so I have to go to my minutes. I think there was a couple codes. There were a few codes that were pulled out for me to review. So those codes were flagged and will come back for future review. And most things were pretty just kind of changing the words, keeping the same meaning. The hypotension, that pairing with self-measured, people wanted to make sure that we shouldn't just make the self-measured blood pressure diagnostic. So I was going to look into that. And then there was something, one of the cardiac things, the several diagnoses that are cardiac, people wanted me to look into that. So those were tabled, those two things. And otherwise, there's a couple guidelines that, like I said, got deleted. And then sclerotherapy, I don't know why, this sclerotherapy for fluid collection is just showing up on all these lines, so it's just there.
So the key question here is, are there, if you could go down to the table at the end of this, if there are procedures or surgeries that we need to make sure we're covering for any of these.
Or even if you have a question, does this possibly need a surgery?
Exactly, then that's the kind of thing we'd like you to be flagging. for us on this issue. It's a little different from others because this is kind of a catch-all. These will just get the office visits and supplies and daily meds.
Quick question. When you say it doesn't pair with, does that mean, what does that mean exactly?
So in evaluation and medical management, the only procedure codes will be office visits, ER visits, and then there's a whole bunch of stuff that we just call our outpatient medical stuff. So like people who might need a home visit, FQHC visits, it's a bit of a mishmash, but it's basically whatever you would expect if you went to your primary care doctor's office. And
Okay.
those
So-
types of services.
I'm sorry, I'm still not understanding when you say doesn't pair with. Does that mean that it's not paid for, or?
So if you have a common cold and your doctor orders a chest MRI, that would not be paid for. Because there's no code for MRI. Because that's not accepted medical practice. There might be a splinter, I don't know if it's in here or not, but let's say splinter was in here, you couldn't get a surgery to remove the splinter. If a bill
The
came in.
procedure doesn't match the diagnosis.
Right, and if a doctor's bill comes in with that as the diagnosis and splinters the diagnosis and like big surgery as the procedure, the computer will kick it out as not pairing, and then a human being will probably look at it and see if maybe it was just
Right,
wrong
but
coding.
just to be sure, the patient doesn't get stuck with the bill, do they?
No.
No, but they might not get a service if that, like, if their doctor orders an MRI for a cough or whatever, it might be denied. But the patient can't be billed.
So more to the point, an epidural steroid injection for back pain does not pair on the prioritized list and would not pair, therefore be treated as not medically necessary under that. For this list here you're seeing right now, the question is, did we miss anything that should be added in addition to that normal basket of visit codes?
Various disorders, go up a little bit. Various disorders of pituitary.
I'm sorry, the acoustics are terrible. Can you speak up, please?
Various disorders of pituitary and thymus. If you had a pituitary macroadenoma or something, are there not certain circumstances in which you would need neurosurgery?
So most of these codes are the non-specific form.
Oh, gotcha. So you would have pituitary macroadenoma as its own code.
Yeah,
Okay,
I
gotcha.
did not include all of the coverage
Gotcha.
codes.
So this is like a throwaway code.
A lot of these are
Gotcha, okay,
throwaway
thank you.
Okay, so it doesn't pair with essentially means the diagnosis and the procedure don't match. Is that correct?
Yeah, they won't be
It's
paid
not a-
together.
It's not an appropriate service for that diagnosis.
Okay, all right, thank you.
All right, so we're all kind of looking through these for anything that would need surgery.
What page are we on? This is like in the, 99 is where it starts. If you're on the meeting materials.
Lactose intolerance. Surgery. I suffer from it.
These are all in the outpatient.
Yeah, all right.
If anything here comes up to the level of hospitalization, that's obviously like outside of PERC's control.
Gotcha. Peripheral vascular disease, unspecified. I mean, obviously, sometimes peripheral vascular disease needs
There's a whole set of codes
that are more
not-
specific.
That are more specific.
Okay,
all ICD-10 codes end up with an other and an unspecified.
Okay. All right.
Because who knows?
Is paniculitis ever treated with paniculectomy?
There's a different code that paniculitis is typically an infection.
Right.
So if it was like a necrotizing infection, yes, but then a necrotizing infection would code.
Would be the code indicative. Okay.
I think generally you want to clear, if you wanted to do a paniculectomy, you want there to not be paniculitis, right? At the time.
Right, yeah, right.
And then if it was severe, it would code.
Same with pathologic fracture.
It's it's pathologic fracture other site. It doesn't mention what site.
Okay.
So, like I said, a lot of these are dump codes.
Yeah, gotcha.
So, April, when I'm looking at this, I'm getting more familiar. So thank you. I think the second time helps. So when I see the code description, you're kind of trying to capture all of the like things that are falling through the cracks or we haven't addressed, the other unspecified. But then in your current line, if there is somewhere else where it is addressed better or there's more specific stuff, then you see like what he was saying, the fracture of bony thorax part unspecified. Then it would say in the current line, it's under 484 closed fracture. So you'd go there to look for additional information beyond the evaluation medical management coverage. But if you only used that unspecified code, only the office visit would be covered. And then you'd have to actually go to the closed fracture of ribs to look for additional criteria, procedures, conditions, treatments, surgeries, that kind of thing.
No, so rib fractures are only on an uncovered line 484. The only procedure on there is strapping of the thorax, which is actually no longer a recommended treatment for rib fractures. There is no surgical fix for just a straightforward rib fracture. Well, if it's open, non-healing, flail chest, and a bunch of other things.
They only do it flail chest, yeah.
Yeah, so there are 468 lines full of codes that we pay for. Most of the stuff that you see is probably paid for if it's a more serious form or a more specified form.
Just from a practical standpoint, speaking as somebody who's horrible at ICD-10 coding, because finding the right
Because it's a horrible system.
is impossible, and you're in a rush and you just find. So I'm guilty of coding with unspecified things all the time. So if a provider is as bad as me at doing that, and they accidentally code, something less specific, is it possible that that thing will not get covered just because
No,
I
it
messed
will
up with
be
the coding?
covered for an office visit, it will be covered,
No, but
let's
the
say.
surgery.
Well, let's say
Your
you
billing
said,
staff will find the
They'll
right
figure it
code
out.
and they'll
Yeah.
figure it out.
or if you refer to a specialist with they have a fracture of unknown location. The specialist will see them x-ray it, say, no, you have a fracture of the proximal humerus, and then this is the surgery that's appropriate for that.
You're right, so there's the billing department that'll be incentivized to figure that out. Okay.
Yes.
Well, yeah, and I
Yes.
think that's now really been put on physicians, maybe not at the VA, but coming up with the correct diagnosis for the treatment plan. Right, and then the EMR tells you, like, if those things don't link, or you don't have the right diagnosis to be ordering this lab.
Oh, it'll tell you?
Oh, yeah,
it
it'll
tells you.
error, it won't let you like finish that, or it'll even tell you that this person's insurance, especially if it's Medicare, won't cover
Really?
This
And
lab,
and
for
it will
this
say, if you
diagnosis.
continue, you have to fill out a non-covered services form.
Or
Oh,
find it,
okay.
or find the more specific and correct.
All right, well, that answers my question, so that's
Yeah, and one of the things that came up this morning is that I had, some of these things are so unspecified, it's like unspecified sprain of unspecified part of the body, and I was gonna put that on what we call the undefined conditions file, which doesn't get paid. It came up like, people, it's a horrible system, people may pick the wrong code, we should at least pay the doctor to see the patient. So all of those where, a lot of them where I had said they're gonna be in the undefined conditions are actually gonna just be in the medical management bucket.
I have a couple things to bring up maybe with these, just trying to be, an advocate, and some of these are not in my area.
We caught a bunch
expertise,
of them,
but
yeah, so if you see one.
I wanna just think about a couple of these, and also we'll become more familiar with what Medicaid covers. So there's type 1 diabetes, that's pre-symptomatic, but, any nutrition services covered, that kind of thing? Would that cover seeing a
Pre-symptomatic
nutritionist?
type 1 diabetes is a brand new area. Type 1 diabetes is autoimmune.
Fair
You
enough,
can
yeah.
have antibodies to your pancreas and not have type 1 diabetes, but there's nothing you can do about your diet because it's autoimmune. You just need more frequent monitoring to make sure you don't progress to develop type 1 diabetes.
Do people still need to know to kind of eat right for that condition?
So
No.
if,
I know.
if
Well,
there's
I
a
know it won't prevent it or make it better
If
or
there's a
anything like that, but-
condition where we know that talking to a dietitian can improve outcomes, like diabetes, like type
Yeah,
2
type two,
diabetes, that will pair with a dietitian, nutrition, whatever visit.
Okay.
If there's something like transient global amnesia, which is what's in front of me right now, that
Sure.
they need maybe diagnostic testing or something, but that you don't need.
Fair enough. So nutritionist and dietitian consult has been thought of for these kind of things. And then I see a couple times there's with sleep disorders, one is other sleep disorders, another one is like related to substance use. And cognitive behavioral therapy is kind of the first line for insomnia type things. And
Insomnia is a
different kind of
specific
sleep disorders,
diagnosis
so-
and it's covered for cognitive behavioral therapy.
Okay, so that's been considered.
A lot of these, like I said,
These are the dump.
these are the dump codes.
Yeah, I'm just trying to do my best with, I'm expecting you to say no.
Yeah, no, that's
with
what
these.
that's what we're here to do, is just
Well,
flag.
yeah,
stuff.
one thing is labyrinthitis, H83. So I know that's inflammation, and it's often caused by a virus or something like that. But sometimes people get kind of weird and hypersensitive about that kind of thing, and so you can do kind of physical therapy type maneuvers to desensitize people with that one during their recovery. But would that be, they would probably code it differently?
I wonder if they would pair that with BPPV.
Yeah, you would pair
Yeah.
probably with a BPV diagnosis. I flagged that though, I will double check.
Okay.
Okay. A central auditory processing disorder, seeing
yeah.
an audiologist, is that
That
the
too.
thing?
We have looked at that code before. Audiology does not help.
Okay.
It is a brain disorder.
Okay.
Is there any kind of sensory processing
There's no
intervention?
treatment that work, and the criteria for diagnosing it is really under extreme criticism or
Page 106, there's AINHUM, which I didn't know what it was, AINHUM, and I looked it up, and it's a rare disease that causes painful constriction of the base of the toe, leading to digit withering and eventual auto amputation, and surgery actually is a treatment for that.
gosh.
I don't think that this is a high yield one, but I don't know that E&M coding only is probably appropriate.
it's L946.
Yep, it's on page 106, L94.6. Anyway, I just know what it was, so I looked it up.
Yeah, no. This is exactly,
It's very interesting.
I've never heard of it, and maybe there's one person at OHP who might need.
Yeah.
Out of your command.
What's that?
Airport?
It's more common
I was
in
gonna
people of
name it after that
African, South
disease.
American, Indian
That's it.
descent, so it's a white community,
know.
so.
Maybe.
I'm gonna see some.
I'm thinking about this list, and the thought occurs to me that this is in a certain sense, a way to help confirm that that doctors and other clinicians diagnose properly and know the most up-to-date treatment.
Exactly.
Yeah.
And this is stuff you can email us anytime at a later date. I don't think we need to get to 100%, but if you see anything or if you saw anything as you went through these materials, let us know now or let us know later. There's still time. Again, we're trying to get as many items on the table, so I'm wondering if we should move on to some of the.
Oh, so here's a DME question: rib fractures, incentives barometer.
I don't think those are DME, I think that they're just,
They're not DME. All right.
I think they're like a spacer for an inhaler, they're just.
Incentives barometer is different. Some of the oversight.
Yeah, it's a little thing.
Oh, sorry, incentives barometers are, pretty sure they're DME. I think a spacer's DME.
Yeah, they're all DME, but I don't think there's any restrictions on them.
Oh, okay. You just get.
I don't know how different we don't PA things that inexpensive.
Okay.
So
Yeah.
I don't know how other CCOs do it.
Yeah.
Yeah. All right.
And it keeps you from getting pneumonia, which is what it's all cost savings.
Well, that's why I'm asking. But it sounds like, you people pretend.
Yeah,
All right.
let's move on, and I think things usually start clicking and people can kind of start going through this a little more.
Yeah.
Tension and cervicogenic headache were called out because they have treatments that can be effective to treat them.
Page 110.
Tension headaches, we've got evidence, and I did an updated evidence review that found continued evidence to support acupuncture. So the proposal is to move tension headache up to the migraine headache line where it will pair with acupuncture, and then we have to do a little modification to the acupuncture guideline to make that clear. The staff proposal was to add chiropractic and osteopathic manipulation to cervicogenic headache. There was concerns that there was no review of the harms that could happen with CMT and ONT of high velocity of the neck, and that's been tabled for further review and discussion at a upcoming meeting. So essentially, if you approving this is really just the tension headache changes with pairing with acupuncture and the acupuncture guideline changes. Any questions about that? Then there was preventive services with no evidence of effectiveness. Just to remind you all, we do have a line for all of the common preventive services, colonoscopy and mammography and all of that. There are some things that either haven't been shown to be helpful or they might be harmful because they might falsely reassure you, or it's a very small number of services. But we, the change would be to basically take that limited number of services and make them not medically necessary. So it's like unlisted vaccine. There are codes that are used for glaucoma screening that are actually not what they're PIC codes, and there's CPT codes that are actually the codes that should be used. It's kind of a thing like that. They're like they're not the most current code, or they are like developmental testing with interpretation and report. That actually isn't the code that we use for screening, for developmental screening. And then there's this intensive behavioral therapy for cardiovascular disease. We actually are supposed to use preventive medicine. So they're just incorrect codes. There's a bunch of Z codes that are on this line. Z codes are typically what we call informational. There are some on line 3 that are more specific. The ones that are on the uncovered line are either things that we don't actually screen for, or there are things like counseling for a family member of an alcoholic that might be very necessary, but you need something else. You need like somebody to be depressed or have situational anxiety or something like that.
Yeah, well, yeah, I guess so. But I mean, that's just kind of part of primary care too.
Yeah, I mean, that could be, instead of informational, we could do medical management.
I was wondering how this
Yeah, I mean,
jives
you know-
tracks with your comments this morning about just making those standard set of office visits covered regardless of diagnosis. Did you intend that these kind of diagnoses would be included with that?
Those aren't diagnostic considerations.
Well,
of
there's
counseling
Z-codes,
stuff.
but there's some other up there too, right?
There's one for
Care wouldn't be
a
exactly
rearrangement,
diagnosis.
a genetic rearrangement, that would be evaluation of medical management.
Not considered.
Yeah, most Z codes are considered informational in the computer systems of insurance companies.
Yeah.
They are things like family history of colon cancer, so that might flag that you need a colon cancer screening at a different interval. But the code would still be encounter for screening for colon cancer.
I'm
So
just
these
thinking though, I
secondary.
mean, you could imagine spending 15 minutes talking to somebody who has a family member with severe alcoholism about use in primary care.
We can
settings.
make that one medical management, that's fine.
You don't usually bill for.
I agree that that Z71, 42, and 52, those can be very important in the treatment of a patient. And the clinician is certainly spending time doing that.
I mean, I agree, Matt.
But we don't
at
bill
Max-
for anything.
Right, I mean, I don't think that, I think primary care providers have probably gotten used to not getting paid for doing that stuff, but
There's no mechanism.
but they should. But
I mean, I
isn't this
guess-
the mechanism?
Like
As we move to value-based care, when we go and see someone for care, I mean, that is something that function certainly adds value or can add value, and may contribute to an improved outcome.
No, because you still need a HCPCS or a CPT code or an office visit code. Like, you have to have
So
some
those
code.
two Z codes, I think we should just put in the medical management. You can talk to your primary care doctor, they could bill it, whatever, but you can't see a psychotherapist. It wouldn't be psychotherapy.
Right, it's just a primary care.
Yeah.
Yeah, and it may be that I'm misunderstanding again, the coding issue. But if you spent 20 minutes of a primary care visit just talking to somebody about this stuff,
You code.
Yes,
You
but
would
you
code
would
what?
code, you would code generalized anxiety, and then a Z code would be informational
So you code
because
the
there's
diag-
that.
Yeah, but they might not have,
Then you code the diagnosis for
they
the,
might not have a diagnosis.
you code the diagnosis for the person that has it, you know?
Well, no, if I'm seeing a patient and her husband is a raging alcoholic and she's crying about it, I would say like situational
Situational
depression,
It's the individual, not the fact that an individual's kid has a problem.
No, I get it, I mean, I get it. Anyways, I don't wanna belabor this point. I think you'd end up, the workaround would be you give this person a diagnosis that they might not have.
So we can make
No,
those two
there's-
medical management, and I think that would just be the same, those two specific codes, those Z codes.
So I'm looking up Z codes and CMS says that they are for social determinants of health.
That's a whole separate thing.
Is it?
Our agency is dealing with
Yeah.
it, not for this.
Sorry.
8.5 to 65.
No, but right now, Z code
Yeah,
cannot be.
so-
the
Oh, the
primary
limited
diagnosis.
number.
So
I don't
what I
think-
propose doing is the bottom two Z codes, counseling for family members of alcoholics or drug abuser, we will make medical management. If your primary care doc, if you come into your primary care doc and say, my husband's an alcoholic, and they give you a counseling on, here's Al-Anon, here's a phone number, here's, safety plan if you're not safe at home, and they wanna bill this, fine. But you can't get psychotherapy, you
Right,
can't get,
And actually, our system right now does not allow us to do
Yeah.
primary diagnosis.
it does for a few things,
For a few things it does.
Yes. it only
So I'm
does-
curious.
I think we're getting sidetracked,
Yeah.
but I really wanna
Yes.
get onto some more issues.
My fault.
Yes.
Should we bring this back or?
I think informational is good for now. I do, because the default is you can't use a Z code as a primary code.
Okay.
Okay.
What, you think informational or was highlighting that when you're saying you're changing them?
Which do you want?
Informational is the thing that makes sense.
Okay,
to
we'll
me,
do
is,
informational.
I think,
So no
standard
change from staff
practice.
proposal.
Yeah.
Moving on to our behavioral health conditions. There are several kind of groups of behavioral health things that are below the funding line. Uncomplicated substance use, which is just like, yeah, I use pot sometimes, not a problem, never had any legal problems. That gets coded, you can find medical evaluation. We have found that somatization disorder benefits from psychotherapy, so that will be added to the conditions benefiting from psychotherapy group. The undefined conditions, again, they're all gonna go on the medical evaluation line instead of undefined. Everything else pretty much is gonna be medical management only. Insomnia, which I think Lisa you called out, that is already on a covered line with a guideline, saying that CBTI or cognitive behavioral therapy for insomnia is first line. That will be called out in that guideline. Any questions about the behavioral health?
I just have a quick observation. When is substance use ever uncomplicated?
I use pot twice a month when I'm hanging out with my friends, and I never have any legal trouble, and I don't have any problem stopping. And we screen for substance use, and I get this all the time. I wouldn't actually bill this, but if I wanted to, I guess I could.
So Ariel, in the past, in the old paradigm, you would create a new line, but right now, since for BUP, you created a new code group, conditions benefiting from psychotherapy, where you're gonna put diagnoses and procedures in for 2027 and beyond.
And when staff gets the time, that group will suddenly include like depression, anxiety, all the other things probably from the covered lines will get folded into it eventually.
I think the clarifying word there is use. It doesn't say abuse.
Yes.
And it doesn't say dependence. It's just
Yes.
use. So your glass of wine is use.
Great analogy.
And why is there a code for that? I don't know.
Well, I mean, and just like you said, you might spend 10 minutes figuring out that it's uncomplicated substances.
All right, moving on to vascular disease. So these are varicose veins, spider veins, post-thrombotic syndrome, which is sort of a heaviness in the legs after you've had a blood clot in your leg. The staff recommendation is essentially not really to change anything. We have a guideline already that tells you when you can have treatment of varicose veins. So there'll just be some technical changes to make, we no longer will have included in a line, it will be medically necessary. We did have one comment on the treatment of chronic lower venous disease. There was something about a patient has to try conservative therapy and fail. That was the sort of thought to be a little bit pejorative on the patient, so we changed it to treatment did not benefit.
Sorry, I'm just trying to get back to this spot. There we go, sorry.
Yeah, so that's the one guideline. The second guideline is compression of vein. Again, things are no longer included on lines. They are medically necessary or not medically
It
necessary.
starts on page 128, if you're following along.
Yeah, and everything in this group will be medical management only, except for things like varicose veins with complications. We're gonna have a group for that, and it's gonna include a covered line, 376, and the uncovered diagnosis. A lot of times these diagnoses are already on a covered, uncovered line. Our paradigm is, it might be, the same code is used for like a varicose vein that's causing severe bleeding and just for one that's just ugly. So we had a guideline and we're like, it's on this line, meaning medically necessary, and on this line, meaning not medically necessary. Now we're gonna take the lines away and we're just gonna say medically necessary, not medically necessary. Yeah. So again, there'll be a few things that already appear on the covered line that will be in this group that's basically the covered line. There was one code for vascular disorders of the male genital organs. I was asked to see if there was actually anything that needed to be done for that.
What page are we on?
Sorry, coming up on the urological,
That one for the male is 132, I believe.
wait, how did we get to urology?
Yeah, we're on vascular disease. There just
Oh,
happens to
vascular,
be a
I'm sorry.
vascular disorder of male genital organs that was
Okay,
called out.
132.
So that was tabled for just staff to look at. Otherwise, everything was kind of
At
considered.
least I think that's what you're talking about. So it has the penile revascularization artery with or without vein graft.
Oh, no, I'm looking at ICD-10 code N50.1. up there.
So is priapism its own thing?
Oh,
Yes.
never mind, so I gave the wrong,
And then all of the procedures that were on these lines will
That's
continue
page
to be
131.
on their lines.
Venous insufficiency, if it says evaluation medical management only, can you get compression
Yes,
stockings?
you can get compression stockings according to the DME rules.
Oh.
Any questions about vascular disease?
I mean,
Yes,
I'm
I
saying
have-
the DME, I'm sorry.
I have a question. I'm looking on page 132 and the two in the top box, 37788 and 37790. Now, not medically necessary for penile revascularization or penile venous occlusive procedure. Why is that?
I can look into that if you want me to look into those codes.
Yes.
Um,
I mean, that's a body part that has a function. So
I think he's in urology.
No,
it's just the next
Yeah.
page down. Yeah, so it's
chronic
where I
lower
was.
extremity. We were talking
I
about
was
this
looking at
earlier.
those
It's
as not
interesting
medically
definition of
necessary.
Oh, got it,
sterility, but
thank you.
not the typical definition.
I'm sorry, but those. Our lines right now are a weird mishmash, and I chopped things up by line. And so some of these things don't go together, and I
So
understand.
let's take those back and look at where the right home for those is.
So, I'm sorry, which codes were they
It's
again?
37780 on the screen, it's just a couple
And the one
codes
below.
down from the one.
And the one below.
37790.
It's the last two codes on that table where we got the vascular version, genitalia, and then it's three, yeah, two codes down.
Any others that you want brought back from that table?
Gosh, these tables are crazy.
nothing's jumping out at me right now.
And again, if you are looking at this later, or for maybe you have a specialist ask you about it.
Okay, and all new guideline notes have a date of last review for. That's a new thing.
Oh, yeah, I didn't mention that. That was requested by the CCOs because they need that for hearings. So every time we review a guideline note, we will update the date of last review. That's nice.
Yeah, getting an opinion from a urologist might be helpful.
Yes, I will talk to them.
Great,
Okay.
thank you.
Okay, so
So
what?
just so I understand the DME thing, when do we have to ask about DME? Or is it automatically,
It is automatically covered, but we don't have DME rules unless there's something that's really overused.
okay,
So
so
like compression stockings have a rule.
we should just assume that DME relevant to any code will be covered.
Maybe not as
Okay.
much as you want, maybe not as often, maybe not as, but the type of thing, it might be a lower cost
Let
thing.
somebody else
but-
figure that out.
Bring it
Okay.
up if you think it's not safe, not effective, or needs to be restricted.
Or could be overused.
Okay, okay,
And
gotcha.
sometimes our HSD colleagues reach out to us, like they did with continuous glucose monitors, saying like, can you work in with clinical indications for coverage?
Yeah.
So that'll happen.
Got it.
So we're gonna move on to general surgery. This is everybody's favorite things, like hernias.
Spinal procedures?
Oh, is
Oh,
spinal
wait, I think
procedures?
Larry has something to say. Did you have something, Larry? Okay, I'm sorry, spinal procedures?
Spinal
Can I ask
procedures?
a question?
Oh, Chris. Okay.
Yeah, I just wanted to know, Ariel, could you remind me I'm looking at R58 on page 131, the very last line, and it ends with the diagnostic workup file. Can you remind me where did that get folded into evaluation and medical management too?
So our codes are typically symptoms. And hemorrhage not elsewhere classified is never used, but if it was, I guess you need to test to figure out where
You
you're
would get the-
hemorrhaging from.
You would
You
get
got
the-
bigger problems, I guess.
You would not get the durable medical equipment for those diagnoses, but you could get the diagnostic workup and office visits.
So most things in the R codes are like cough, fever, abdominal pain. They're non-specific. They would need diagnostic testing, but they don't need DME or surgery. You wouldn't do surgery for somebody for abdominal pain. You would hopefully have like
Signs and symptoms. This is signs and symptoms, essentially.
All right.
Okay, thank you.
Okay, so do you all want to talk about spinal surgery? Because that was tabled to bring back WBS. I think that might be better use of our time to talk about it when it's a little bit more.
I didn't know it was tabled.
Sure.
So then general surgery, this has a couple of things in it. You can see there's a table, if you page down just a little bit. This kind of summarizes stuff. Ventral hernias sort of along the midline, aren't currently covered. I did an updated evidence, well, kind of fell in my lap. There was a very large new study that came out in the fall, where they looked at about 30,000 patients who had ventral hernia repairs. And I've always quoted that the rate of needing re-repair was about 40%. Apparently it's 40 to 70% within 5 years. So we're gonna continue non-coverage for ventral hernia repair.
This is page 208.
Cholecystectomy.
So not non-coverage, not medically necessary, right? Yeah.
Right, it is not medically necessary to do surgery for ventral hernias. Cholecystectomy, where we have, again, sort of this artificial funded and unfunded to show as our stand-in for medically necessary, not medically necessary. We're gonna put those two things back together and just kind of call it what it is. It's medically necessary to get your gallbladder out for the following things. If you don't have that, you don't need your gallbladder out. And then there was some very strange peripheral nerve, digital nerve injury that ended up on a general surgery line. So we're just going to cover that with current coverage. So we're going to create a new line, or new code group, excuse me, called complicated hernias and persistent hydrocele. It's going to include what's currently line 167, as well as what's in line 517. So we're putting all the hernias into one group, and hydroceles are basically a type of hernia. And there is a clinical guideline, which is a modification of guideline note 24, just with updated sort of technical updates. We're going to have a new group called, complicated stones of the gallbladder. There's going to be a lot of stuff from line 55 in there, as well as some additional stuff from uncovered lines, and the guideline pretty much the way it is with the edits that you saw a little bit earlier in the meeting. And then there's these peripheral nerve things. We're going to put most of those on line 206, which will become code group 206, it's a covered line, just general modifications to the current guideline. There will be just a small change where we're actually going to cover some digital nerve repair that I don't know why it was hanging up below the line. So for complicated hernias, you can see that we're
Can I
just.
ask a gallbladder related question? So am I reading that correctly? So cholecystectomy would just be covered for cholecystitis and biliary, what did it say?
So it's our current guideline. We cover it for cholecystitis, abdominal pain, biliary colic without cholecystitis, and then the gallbladder, we changed that a little bit earlier in the meeting, so hypo or hyper.
Oh, what about like gallbladder polyps and cancer and stuff like that?
If it's cancer, it's on a different line. Cancer is usually very widely, there's so many procedures that would pair with the cancer.
Okay.
Radiation, whatever, all that stuff.
And then what about large gallbladder polyps?
I didn't come across them, so they must be somewhere covered.
Okay.
I think we do it by exception.
Okay, we
Because I
can look.
remember looking up the clinical guidelines about what size
I just quickly,
Quickly,
the 10 millimeters, so quickly, I mean,
Yeah, and there's some change too, I think.
Okay.
Sometimes they
Um,
obstruct.
I will make a note to look for gallbladder
I
polyps.
think we're kind of only sent them when they think they need to see a fair amount of them that they just watch, and that never gets us.
Right.
It's just serial ultrasounds. I don't think it's incredibly common.
No,
Which is why I think it's common that we do it.
Yeah, that's on line 634, so we can look at that.
Yeah, those polyps are common that we approve for exception over 10 millimeters for increased risk of cancer.
Oh, it is, they actually appear on page 214, so Ariel, maybe got that one out.
Okay, my numbers are different, so. What's the, do you?
K
have the-
82.4.
Clusterostosis of gallbladder?
That's what I got when I Googled
Okay.
polyps of gallbladder.
I like that to look at.
is that doesn't
Isn't
sound.
that when there's the cholesterol wall? That's what it sounds like.
We can look at that.
Yeah, I will look up what gallbladder polyps are coded as and make sure that we cover it.
Those are cholesterol polyps,
Okay.
might be other polyps.
Yeah.
And it may be one of these other specified diseases where they don't think, like, they make all these useless codes and then they don't make useful ones.
I know, yeah, you can fall from, fall from hitting a lamppost,
Yeah.
second encounter,
I would
My-
like.
my secret is,
Second.
head and
Sequela.
or like brainstem herniation without ever regaining consciousness, recurrent encounter.
Yeah. Let's move
We
on.
brought religion into this.
I think you can fall like turtles.
There's something about for astronauts too.
Anyway, so essentially we are keeping the status quo. There were a couple of nerve lesions that I had flagged earlier that I tabled and I will bring back to make sure that Katie had pointed out there are effective treatments for those. And so I'm going to, that's on my to-do list.
Sorry.
So essentially the intent is to continue to cover hernias the same way, just changing words, making things not medically necessary instead of included on lines or medically necessary. Same for gallbladders. I will look for gallbladder polyps. And there's some edits to the gallbladder guideline that happened earlier. We'll make sure those get reconciled. And then the nerve injury guidelines, again, will just be word changes without intent changes, really.
We do get the polyps on this K 2.4.
Kate, I'm sorry,
K
K
2.4, just I think.
82.4.
Yeah, that's the one we just,
That's what we get at Sunrise.
that's the.
Or at least I've had it since that.
Okay, I have it flagged, that is tabled.
Yeah.
So when you approve things, if I say it's tabled, you're gonna approve everything but the tabled items, and then those you'll see, they will haunt you.
Is there much more on this? Cause I
Well,
think
aren't
there's still
you?
other stuff.
No, there's not a lot more on this,
Oh,
we've got breast surgery, GI, and urology.
All right,
together.
let's see
So,
if we can do it.
yes, breast surgery, there's only a couple of breast conditions that we don't cover.
So this is page 257.
So what we are going to do is basically, there's gonna be two breast cancer surgery lines. Yeah, or I'm sorry, two breast surgery lines. Cancer or high risk for cancer and no cancer. The no cancer will include macromastia that meets our current guideline criteria. We're adding fat necrosis at the, because of, if it's the breast surgeons we're talking about, it can become extremely anxiety provoking and sometimes it's a diagnostic issue. So, or it's a post-op complication. So that is the main change. Breast surgery, breast reconstruction revision, macromastia, just kind of wording changes. We are gonna add coverage for fistula of the nipple, which is basically an abscess. We should probably have already been covering it. We're gonna add it, like I said, for galactorrhea. Mastodynia, we've changed it from diagnostic workup to evaluation and medical management. It's basically needing a workup to see why you have breast pain, but it could just be an office visit and maybe ibuprofen. And then we have added a couple of the acellular dermal matrix we talked about earlier, that's being moved. Have previously been moved. And then a couple of other procedures that are uncovered. All of the procedures essentially are uncovered lines. We're just gonna dump them into one of our 2 new breast surgery buckets. And then going on to gastroenterology.
Page 268.
These are all conditions that don't have any, okay, the vast majority are just office things, they're medical, so they get the medical evaluation. Cyclical vomit or abdominal migraine will be moved to the migraine headache because a lot of the treatments are the same. There's a food allergy induced enterocolitis that'll be moved to the food allergy testing line. There's a hourglass stricture. There's a couple of things that need treatments, and I found lines that had the appropriate treatments, so you'll see them moving. If it's a current line number, that's going to convert to a code group. And then the other thing with this was, we're deleting the
Sorry,
guideline.
Not to belabor the point, cyclic vomiting in migraine will move to migraine, but what about just cyclic vomiting?
That is in here, I think it's just office. Here, I think it was at the last code here, cyclical vomiting unrelated,
Okay,
yeah.
gotcha,
just
okay,
leave out.
all right, sorry.
Yeah.
Yeah, unfortunately, that is a problem, and then we also only cover gastroparesis if it's unspecified or related to diabetes, idiopathic or related to diabetes. We don't cover the kind of generic. So we're just gonna cover all of it with the same guideline and not really make people tell us exactly what type it is. And then the guideline will be changed to just have appropriate wording changes. Any questions? And then I was instructed that there were 3 diagnoses that were flagged by staff as possibly being high pharmacy costs, and I've been instructed to possibly look at a guideline with our pharmacy colleagues. And then
General thing about just some of the things I've seen in here. You know how a lot of things can be kind of psychosocial or have that kind of component. Would the E&M that we have here cover psychological interventions?
No,
Or
'cause
is that a
that's
separate kind of thing?
That's a separate
No.
That would be a separate kind of thing?
Yeah.
Separate diagnosis, you have to go to
I mean,
the.
office education or some office counseling is covered, but not like a psychotherapy visit.
And then maybe I don't know completely about the cyclical vomiting syndrome, but isn't that kind of a behavioral thing?
It's really unknown.
It's
whether
really unknown. So there's no real intervention that has any.
But if it's like part of an eating disorder, that's a different diagnosis
would
that
be-
does pair with like psychological interventions. But like this diagnosis just by itself,
Okay.
office visit.
Thank you.
I think we have to keep moving because we still have another thing on the agenda, which is.
Yes, thank you. Yes, okay, so urology, I am condensing down the urology lines. There's a whole bunch of covered lines and some uncovered lines that are gonna all become a group called urologic surgery. Partly that was because meeting with multiple urologists, they couldn't understand why we kind of parsed them out the way we did. There will be 2 additional groups. Cancer is always kind of a separate group, so urologic cancers, and then lower urinary tract symptom, because that has a lot of very specific treatments and things you want to control. So those things are carved out. Otherwise, you've got an obstruction of your ureter, you've got a really bad problem with your testes, whatever, it's all the same line because we don't think it's overused or has these other issues. There were redundant pupus. So this group decided that elective circumcision was not a medical necessity. It could be a social, emotional necessity, but it's not medical, so therefore it's outside of the benefit package. There's some guideline note changes that need to be made just to bring, again, they're just kind of formatting changes. There were a couple of changes that were suggested by the urologist. The first, for penile anomalies, we only covered treatment of acquired anomalies if they were the result of surgery. The surgeons were like, we don't care if it's a post-op kind of thing or development, a disease that developed, we treat them the same way. So we're taking that away. But we pulled out buried penis, which is part of that guideline, and I'm looking into that further. the surgeons wanted us, so for benign neoplasms of urinary organ, we allow surgical treatment for bleeding or urinary obstruction. Or if you have bleeding urinary obstruction, the surgeons wanted, or pain refractory to over-the-counter pain medicine, but that actually ended up not being approved. BBBS thought that would be something that would be very commonly seen for lots of conditions, and it would kind of be a not fair kind of thing.
I have a question on page 273 in the plain language summary. It says, surgery for pain with erection is not and should not be covered, though urology experts recommended adding this coverage, and then the line below that, surgery for masses in the urinary system should be covered. Okay, that's
right, the initial staff recommendation was to agree with the urologist to add that, but BBBS disagreed, and so there's a they approved a modified.
I'm sorry. Can you speak more slowly, please?
So the plain language is the surgery for masses of the urinary system should be covered if medication doesn't provide relief. BBBS did not agree with that. So what's coming to you is a modified recommendation that does not include that. Surgery for pain with erection was recommended by the urology experts, but staff did not make that change. That's why I called it out, because our experts and staff did not agree on that one.
Okay, so okay. So is there a proposed change to cover that?
No.
Okay. So if urology experts are recommending that,
I mean, and that happens all the time, Larry, right? Where we may end up disagreeing with specialists on a given thing. And it sounds like BBBS had debated this and came up with that.
huh, okay, because it sounds to me like that's a normal body function and an important one. So that's why I'm highlighting that.
If I recall correctly, I think there are some federal limitations on sexual dysfunction and what can be covered, and I think that was the instruction we were given, that there are some federal limitations on this. And
But there are some federal limitations?
yes,
Yes, treating sexual dysfunction is not part of the OHP benefit package outside of like gender affirming care, because nothing's outside of the scope of that.
That may be a larger question beyond the scope of our committee right now. All right.
Okay, I'm just gonna
Yeah.
register that doesn't make sense to me.
Fair enough.
Fair enough. We gotta keep moving because we gotta get
And
to
agree. And then that was all of the buck. So if you could approve buck
All right, so we gotta approve this whole thing. Good job, everyone.
with the additional modifications made at this body. I salute.
Okay,
Second.
all right, Jessica.
Okay. So Adrian Irwin,
Approve.
Mark Buckles,
Approve.
Ben Hoffman,
I approve.
Max Kaiser,
Approve.
Lisa Kouzes,
Approve.
Linnea Lindsay,
Approve.
Larry Lyon.
I'm going to approve, but I'm also going to register my disagreement with the surgery for pain with erection not covered.
Right. Chris Pinzon,
Approved.
Catherine Shable,
Approve.
Leslie Sutton. Oh, must have stepped out again. And Devin Kansagara.
Wonderful, yeah. All right,
The Ehlers-Danlos syndrome.
yeah.
We kind of discussed this together with fibromyalgia because there's some overlap of these conditions in sort of a Venn diagram sense. We will go through Ehlers-Danlos syndrome. This is a condition that we have spoken about before. There are various forms of it. The most common form is hypermobile EDS. We have previously done literature reviews that have found, unfortunately, the condition itself does not really have good treatments. The sequelae, for example, dislocated joint or a joint injury, physical therapy and DME, et cetera, would be useful for that. There is a international practice guideline published in 2017 that is the only real practice sort of guideline for treatment at this point. We had multiple public comments that were submitted during the advanced public comment period. They all agreed that we should move this to a covered line. The main disagreement, I believe, in that group was that they felt physical therapy should be covered. We also received some later comments that were in the link that you got yesterday or the day before with late public comments. So this is a rare condition. It's currently on a non-covered line. Previously, staff had recommended moving it to a covered line that would allow it to pair with medical treatments only. We were asked to form a guideline to kind of help guide care because there was some concern about inappropriate care. The staff recommendation has stayed somewhat the same, moving this to line 141, which includes diffuse disease of connective tissues, and removing it from the uncovered current line, and then adding a new guideline, which is on the screen, and it will be on the screen in front of you in a moment. So it essentially says that it's included on the covered line when the patient has a known genetic marker or when they otherwise meet the criteria outlined in the 2017 International Expert Guideline. Diagnostic testing was covered when medically necessary. There's no effective treatment for the syndrome itself, but this condition may result in multiple manifestations, including joint sprains, strains, dislocations, and cardiovascular problems, for which treatment should be covered when medically necessary and appropriate. There were a few edits. You can see we struck a few things. Patients who meet the 2017 diagnostic criteria for vascular EDS should be monitored with echocardiograms no more than once per year unless symptomatic or having no cardiovascular disease. Because of frequent comorbidities and multiple manifestations of EDS, provider and plan should carefully monitor interactions of prescribed treatments to avoid contraindications and harm. For EDS patients who also have chronic pain, see Statement of Intent 5, Treatment of Chronic Pain. Questions, input on the modified staff proposal, or the VBS modifications and improvements to the staff proposal?
And just acknowledging that I think there's a disconnect, the invite on our calendars ends at 4, but I think the meeting was intended to go till 4:30, so.
Apologies.
Thank you for your patience.
We need a motion of nobody's commenting.
Yeah, any questions or concerns?
Yeah, just a quick question. So with this slight change, the people who had testified in the public comment about EDS, I just wonder what their response would be to the change. That's all.
We did have some testimony this morning, verbal testimony, and it seemed like they were generally in support.
Okay.
Now covered diagnosis.
Yep.
Okay.
Do we have any additional public testimony now?
No, we don't. We don't have anybody ready.
Just signed up. So I mean, in other words, this is moving in the direction in which much of the prior testimony had suggested, and you know, with some clarification. Chris, were you about to say something? Maybe
I thought it aligned with the things that we'd heard, and from our last discussion, I thought this was a really good resolution.
Okay. All right, so I'm not hearing a lot of disagreement or concern.
Do we need a motion? Okay, I move to adopt it as presented, which is with the edits.
All right.
I'll make the motion.
All right. All right, we're good to vote then, Jessica.
All right. Adrian Irwin.
Approve.
Mark Buckles.
Approve.
Ben Hoffman.
Approve.
Max Kaiser,
Approve.
Lisa Kouzes,
Approve.
Linnea Lindsay,
Approve.
Larry Lyon,
Approve.
Chris Pinzon,
Approve.
Catherine Shable.
Is gone.
Okay, Leslie Sutton. She must still be gone. Okay, and Devin Kensagara.
Yes, approved. You're getting good.
I'm trying.
All right, so I think did we do everything?
Can we talk about fibromyalgia for a few
Yeah.
seconds?
For
So-
2 seconds?
Yes,
Fibromyalgia.
it's a BUP item.
All right.
The proposal is to add it to a line, which is a medical visit only line. With fibromyalgia, currently in the current line is chronic pain syndrome, which is, so according to our, pain commission, that their modules say that you should do that, it's appropriate, so we're putting them in the conditions benefiting from psychotherapy. Chronic fatigue and fibromyalgia will stay on a medical only line. The one change that happened this morning is that the current fibromyalgia guideline is a practice guideline, not like a coverage guideline. We were gonna delete it in 2027. That's moved up to November 1st, 2025, because everyone agreed that it should just go away. That's the first time we can delete it. And we got some public testimony. I think people are okay with that. Staff will look at guidelines similar to EDS for fibromyalgia that might be brought back at a future date to discuss. Any questions?
Quick question, what is GN 135?
Guideline note 135. That is the current fibromyalgia guideline.
Oh, and that's what's crossed out below.
Yes.
Okay, great, thank you.
So we have to vote on this?
Yes.
Okay. Anybody want to move?
So moved.
Great.
Second.
Awesome. Jessica?
Time for another vote already. Okay.
Yeah, we're fast.
Adrian Irwin,
Approve.
Mark Buckles,
Approved.
Ben Hoffman,
I approve.
Max Kaiser,
Approve.
Lisa Kouzes,
Approve.
Linnea Lindsay,
Approve.
Larry Lyon,
Approve.
Chris Pinzon,
Approve.
Catherine Shable.
She left.
She left. Okay, and then Leslie, did you come back? I will take that as a no. Devin Kanzagara.
Yeah. Yes, approved.
Ryan.
All right.
We have one more item, if
Oh, we
you
do?
could indulge
Okay.
me.
Yeah.
Trigger point injections. They were
Ah.
discussed this morning. These are injections that go into sensitive trigger points in muscles. We had previously reviewed the evidence that they are effective for acute, meaning less than 6 weeks. The guideline that staff had made, though, said that you needed to do at least 3 months of conservative therapy, so that it didn't really make sense. The evidence was reviewed that we reviewed, and the studies were just sort of a minimal benefit into the short term. Staff had revised the recommendations to include not covering them at all, putting them in excluded guideline 2, or covering them and with a new guideline. And VBS was quite adamant that we should put them in excluded guideline 2 because there is minimal evidence that they are effective for anything other than short-term relief, and that you would need multiple repeat injections. Sarah Love did express some concerns that she does see good short-term pain relief in her practice, but that the movement to exclude guideline 2 was approved.
Yeah, what do you all think? I mean, practically speaking, this is something that can be done in a few minutes in a primary care visit.
What
See, I don't do
It's
that.
not effective.
what page are we
Yeah,
on?
I'm not arguing for it, but I'm just
Page
saying,
number.
in terms of the practical impact,
Page 288.
Oh, thank you.
Volume's large.
how does it differ from an evaluation management?
It's its own code. It gets billed, it gets paid separately. It's a procedure.
It's a procedure.
It's like acupuncture or something.
Yeah.
As effective as no injection.
Yeah. All right, so, any questions or concerns about that?
No concerns.
Okay. All right, so last vote? All right, press the finish line.
Motion approved.
All right.
Right.
Second.
Anyone second? Oh, did you move?
Yeah, moved.
Second.
All right, good. Jessica.
Okay. Adrian Irwin,
Approved.
Mark Buckles,
Approved.
Ben Hoffman,
Approve.
Lisa Kouzes,
Approved.
Linnea Lindsay,
Approve.
Larry Lyon,
Approve.
Chris Pinson,
Approve.
Catherine Shable.
Gone.
Gone, that's right. I keep forgetting that okay, left early. Okay, and I assume Leslie's not here. Devin Kansagara.
Approved. Hey, do I need to vote?
Max.
I think you
My
did
motion.
vote.
Yeah.
I approve too, despite motioning
All right, the last minute controversy. Very good. Okay. All right, I think did we do everything?
We did everything.
All right, I just wanna say to Ariel and the whole team, I mean,
Yeah, thank you.
remarkable work. So I propose a round of hand for amazing
We get to the end
work
of,
here.
I expect.
We can clap each time.
Yeah, this is like,
Yeah, a lot of work.
yeah, I would be dreaming about this stuff if I were doing that.
I actually have.
I bet. I bet.
All right, our
Which
next
category is this?
meeting,
March 20.
same time, same place, March 20th, and it will be, should be for 3 hours, so just, I think there was just a little mistake on the invite, but we'll see you then.
Thank you for all your work.
Thank you.
Very good.
Thank you, Ariel.
Okay.